Hey, hey.
But put that hand down, you motherfucker.
I've been in here for minutes watching you. Yeah.
Okay. I'll just screen share what I'm doing here.
Yeah, I'd like to learn what you're doing.
Yeah. Okay. Let me.
I'm also microwaving food, so when it comes out, I'll just grab it quickly.
Hey, you can come and go. I mean,
No, I want to see. I really want to see how you do that. Yeah.
yeah, we can text back and
Literally,
forth.
it's right next to me. Yeah.
Yeah. Um,
Let me just grab it.
Dog.
Yeah.
I'm gonna set up. I'll have to show you later because last night I fucked up.
Yeah.
I missed the first part because I didn't click the button of show sound.
Oops.
Yeah, I forgot. Hey, what the hell? Hey, you make mistakes.
It happens.
But you know how many they had tons of people. I'll tell you about that later. So I'm gonna set it up right now.
If you share the screen, I can learn what you're doing here.
Yeah, well, I'll tell you what I'm doing right now. Right now, I'm gonna go to the website of the MedTaian. I'll give you. It's a big Chinese. I told you about the guy. Remember, he wanted to rip me off.
Yeah, yeah.
Yeah, and so I don't know if he knows I'm there with other people, but I don't think he would do anything. He didn't write to me. I wrote to him. Okay.
Let me grab.
Okay, dog. Let me share the screen.
Just setting this up right in front of you so we can talk. Okay, I'm back.
Okay, now the way we do this, we basically screen share their transmission,
Yeah.
their Zoom as a panelist, I just screen share that, which I'm going to do now. You see where I'm at, right? I'm in the Chinese. It's Neurosurgery News. It's a big website. They get lots of people to come to them. Anyways, they have it listed. Brazil, China, that's the conference we're televising.
Yeah.
And they had UHAs up there too when they televised UHA. Okay, and this is it right here. It'll come up, it'll come right here. You can see the screen, right?
Yep.
The thing is, I didn't have the fucking sound on. I shared the screen, but this time I made sure. Matter of fact, I'm going to go off the screen share.
Yeah, when you have that small button, you got to click, right?
Yeah. That's I couldn't figure out. I was checking the computer. I was going crazy. Barbara was talking, but hey, it happens.
Yeah. You can just say it was a technical difficulty.
I did. And people understand that. Everyone understands technical difficulties with computers. Everybody knows what that
means. You don't have to say fucked up or something. Just say it was technical difficulty.
Yeah. Well, I got to get used to making money.
Yep.
Because we can make money, man.
Yeah, for sure.
Man, that's what this guy said to me when I said I'm going to charge. He said it's about time.
Yeah.
Yeah. So, okay. Anyways, we shouldn't feel bad. Okay, let me set it up. I'm going to go off the screen share, right? I'm going to go on again. Okay, now I see share computer sound. That's key to put on. Like when I'm putting on this the video where it's going to be. It's right there because I had the damn video on with no sound for Barbara's presentation.
I've done it too.
Yeah, but anyways, it happens, and he got a lot of people from WeChat, 10,000 people. Wow. He got 1,000 from my Facebook page, just the Facebook page.
Wow. That's amazing.
So yeah.
But now it's just that's like normal for you.
Yeah, well, it's a China thing. I mean, it's I'm not putting too much stock in it because it could end, That guy's kind of an idiot. I hate to have to depend on him, We had a run, I had a run in with him before. Not a run in, but I mean, he tried to rip me off.
Yeah.
So that, you know, that's not a very nice way to start a relationship.
But it's good experience doing this.
Yeah, yeah.
You can use it as a business.
But we could do it, do our own China thing without him. We got the name, dog. The name is around. People know the fucking name.
Yeah, you can invite other Chinese surgeons to do the same.
Yeah, like Ben loves us. He's a guy televised from China and Spain. He loved it. He couldn't make the trip. Remember, he couldn't make the trip. So he's a big China connection now with Yuha. And he wants, I think Yuha loves him because he's been trying to do this for a long time, but no one, you know, the hospital doesn't help him. You know, I don't think he really pushes. It's a shame. He's been waiting to teach for years.
Yuha?
Yeah. He said that this is the best I've felt since I came to China.
Oh, wow.
Yeah, that's pretty nice to say that.
He was getting a bit older, approaching retirement, maybe.
Well, he loves to teach. He's a born, I mean, he just loves to teach.
Yeah, I would like it too, I think.
Yeah, well, you know,
Too bad, never
it's
got
enjoyable when you're talking about your passion.
Yeah.
Shit. So,
That's right.
Yuha's working well, and he's very happy. And I don't think he's the kind of guy that if some big operator came to talk to him, he'd say, no, I'm with John.
Yeah, that's good.
He's that kind of guy.
Well, like there isn't anybody else though. You are the only one, I think.
Yeah, that's true. You don't have a choice.
Yeah. Well, not any other choice, but there's no one compares to what you've done.
Yeah.
Right? You kind of cornered the market. You're the gecko, Gordon Gecko.
Well, you know, dog. The only reason is most other people have fucking jobs. They couldn't do that. Couldn't take the time to do this shit.
Well,
They have jobs.
Maybe you're the first professional neurosurgery conference presenter ever.
Yeah, we'll see. But I think it can be monetized. I just got to figure out, dog, how to monetize it. You know.
I thought that Indian guy was a tech guy. Turns out he's a pediatric neurosurgeon, right? The one who was in charge of.
Yeah. He's okay. You
Nice
know,
guy.
I'm learning. I got to learn how to handle people. You know.
Yeah.
First of all, I don't like the guy from the start. But he's getting better. He's getting a little more humble. He was very arrogant at the start.
Oh.
But you know, I got to learn how to handle these people. You know, I can't.
I got to learn that.
I can't get everyone pissed off at me. You know what I mean?
I got to learn that skill too.
Yeah, because Yoko, she doesn't want to hear problems. She just wants to have a channel working.
Yeah.
You know, and this guy was complaining to her about me, and Ike was defending me. You know, it was bullshit. I mean, it was bullshit.
What subject?
It was what I was saying. He's not doing this right, not doing that. I was criticizing the motherfucker.
Oh, I see.
And he didn't like that.
Okay.
He called Cato, help.
Wow.
But no big deal. But anyways, I'm glad to say it's working out. It's working.
You're a nice guy. You know, that's what it comes down to. People, when they meet you and they get to know you're a nice person, they'll work it out.
No, I'm tempering it, but he's okay. He's actually drawing people into the I mean, there's good points to him. He does a lot of promo, which I really love. He helps.
Yeah.
You know what I mean? He does promo.
Right.
Not many people do that, and that's very nice. He makes video stuff for the website. But anyways, I'll talk to you later, dog. Eat your food. I gotta get set up. Make sure everything. Should I
come back 10 minutes or what?
Yeah, 15 minutes, 14 minutes.
I'll be back. You're making the links?
Hey, Doug,
No.
I'm just waiting for them to start. 5 minutes. They were kind of late last night.
You're still sharing the screen, by the way.
Yeah, I'm waiting for them to start. I'm just gonna leave it there.
Oh, of course, right. That's right.
I'm getting all set up.
That's right. Okay.
Dog, you're making $250, man.
That's a lot of ramen.
Man, oh man, I didn't even think about this, but when he said, "Yeah, I'll pay that," because if we brand it, I mean, we're branding it. If it gets popular to be seen,
right? You're already a brand. You're already the only brand. I mean, it's already.
Yeah. So we just have to get the people to, pony up, mother.
Yeah, just say this costs $250. That's a lot of ramen. Special this month.
So you eat ramen. You like? I like chicken noodle soup. My favorite.
Yeah, I'll eat anything. Right. You're already a brand. You're already the only brand. I mean, that's already.
So I can see now. I should have tested it before the broadcast. Yeah, that was, it was no excuse. And then I would have seen, oh, I can't forget to do that. Because now I'm testing it. I can hear, the video is going to be heard.
Yeah.
Because my voice is being heard, on the broadcast. So I can see now, I should have tested it before the broadcast. That was, no excuse. And then I would have seen, oh, I can't. Most of my time I spend like posting things on Facebook. And whatever.
Yeah.
Just posting. Because dog, these people don't promote. They just don't know that you don't just put one post on neurosurgical cocktail and that's it.
Yeah.
That's all I do.
Yeah.
With some of the conferences, most of my time I spend, I can't find out information anywhere on the internet. What time it starts, who's speaking. It should be easy. I mean, that's a promoter.
Right.
So we have a head start in that respect. They'll learn.
Yeah. You know how we used to make jokes about the taxi drivers and Indians? So so there was no sound on this video. This can be easily solved just by adding the soundtrack of a Chinese food restaurant.
I know. Oh God.
They'll just think that's fucked up. I can get that. If that ever gets out internet, history.
There you go.
Stereotypes. Yeah. Kung Fu, Kung Pao. Fly lice.
Yeah. It'd be funny if we start making it in China. I'll go wherever, hey, whatever works, man.
Oh wait, you're live right now already. You're live.
Yeah. Well, live on YouTube. Yeah. So yeah, we do gotta be careful what we say, but.
Oh, can you cut that out?
Yeah. We edit it. No,
okay.
We're gonna edit it.
Who edits it?
Dan Vargas. He's a good Brazilian editor.
Okay, good.
He's pretty good. Because dog, editing is just too much.
Yeah.
It's too much. So.
I know. Believe me.
Yeah. It takes the fun out of it. You know? And I want to enjoy it.
Yeah, exactly.
So. Dan Vargas, he's a Brazilian editor. We should be starting momentarily, and then we'll have to silence, but we can text each other.
Yeah.
It's too much. So.
I know. Believe me.
It takes the fun. The code is on the website. I got to put the code on the website. Do you know coding, right?
Yeah.
I'll show you exactly later, but you just put the embed code on the WordPress website.
Right.
Do you know about that?
Yes.
Oh, okay. So yeah, you can easily
Show
do
me
that.
again as a refresher. I'd like to learn. Yeah, again.
Yeah,
But I've
yeah,
done
just
it before. I've done it before.
yeah. I've taken. Okay, the first thing I did was I started the YouTube on the with the Zoom, right? I started early. I don't care. People can watch it. I can turn it off. I can turn the video off and stuff, whatever. But that's the first thing I do is set up that. Then I know it's going to play live on neurosurgical TV. Yeah, I've taken. Okay. And then just promote.
And you have the $50 a month plan, right?
Yeah, yeah. I tell you, it's tough to get a hold of those guys, man. They're so busy, and they sent me a bill for, I thought it was a pretty high amount. I'm trying to dispute it, but I can't get a hold of anybody. So, but by and large, they're good. Yeah. I mean, they're good. They're the best game in town.
Yeah. And you have the $50 a month plan, right?
And if people did them, they would know why they're good.
Yeah.
They make it very easy to arrange conferences, which is really nice. It's really nice. It makes it convenient. I can't get a hold of anybody. So, but by and large. Yeah, I'll be leaving momentarily. They'll start any second. The best game in town. Yeah. Then I got to put my cell phone on mute. People did them, and we can't talk at all. Okay.
Yeah, got it.
They make it very easy to arrange conferences, which is really nice. Yeah, I'll put us on mute now. Dog, are you there?
Yeah, I'm here.
Yeah, they're doing, you see this simultaneous operation live broadcast team of these doctors.
Yeah.
They're operating. I mean, that's going to not be too exciting, I don't think. For me, I'll just basically doze.
Yeah.
But I got to remember not to put the camera on me.
Yeah. You just set the timer.
Yeah, they're doing, you see this simultaneous operation live broadcast team of these doctors.
Yeah.
They're operating. I mean, that's going to not be too exciting, I don't think. For me, I'll just basically doze.
Yeah.
Okay, I'll get on mute. I gotta remember not to put the camera on.
cases, we didn't have any problem. We had one problem with an adult patient because of anxiety, and we almost had to switch and do it not awake. But after a while, the patient started to cooperate and things could progress. So this was the only case that we almost had to stop the awakening process. But I do agree with a child, it's better to not to awake if it's not cooperative patient.
小霍，他们的病例都接受了，我们没接受，病例接受了。
没了，对吧？那个是张总，先把小宝那儿先静音了，就是我们的手指先静音了，这儿。
Well, I think it's not a tough case. Superficial. And I hope you're going to have success in this case. It's easier. Then infiltrative glioma in the left side in the temporal lobe, involving the language area, and so on. That's the difficulty that we have in Brazil as a big country. Also, we have different centers and different centers. Here we have a private hospital and we can operate on public patients. Neuronavigation is not so easily to public patients, just in reference centers. But for private ones, they can have access for that. But we try to do our best. So here we need to have a good anatomical relationship to know where we can find instead of trusting in machines, you know. That's why anatomy keeps alive in Brazilian neurosurgery, because neuronavigation not easily find. Do you agree, Igor, with us?
Sure. Sometimes we cannot have neuronavigation. If you have, for this case, it might be helpful, but I wouldn't say it's full necessary. But this is a difficult that all of us have in our public health system, unfortunately.
Yeah. We decided to center the craniotomy more in the lesion, the more frontal area, instead of exposing the temporal lobe, because as we see, it's the left side, and we're taking care not to damage the venic area because she's 12 years old. So less invasive as possible to keep her in a good functional status afterwards. Professor Wu, what is your opinion about the I4F in this patient? Is it an important white matter tract in terms of cognitive deficits?
Yes, I think I4 is very critical for ventral language pathway. So if we cut the I4, the patient will suffer from conductive aphasia after operation. But this case, because as I mentioned before, this is a child, so the ability of neuroplasticity is relatively well than adult cases. So for child patient, I think it is not essential. If we can totally resect the tumor, I think is much critical than the language preservation, because the patient language disorder will recover maybe 3 or 6 months later. So I noticed Eduardo, he is on the line. I think he is expert for neuroanatomy. Maybe he can give us some comment on the I4.
Eduardo, welcome.
Oh, Dr.
Eduardo Rivas. Can you comment this case? Deixa eu trocar luz. Professor
Eduardo?
Rinson,
Eduardo, can you switch
you are
on
mute,
the
you are
phone?
mute.
Yes.
You are mute.
Professor Rinson, what do you think about the relationship of ultrasound aspirator in these functional areas? Is it low with what the risk of these tools in neurosurgery? In this,
I think CUSA, you mean CUSA aspirator?
yes, CUSA.
I prefer to use the CUSA instead of the routine suction because we can resect the tumor volumetrically just like a curve. So very elegant facilities for glioma surgery. I like
Yes, thank you.
CUSA. Eduardo?
Is Eduardo there?
Eduardo, can you give us some comments on IFOF?
Hi, I believe my connection now is better. Sorry for the interruption. And first of all, Dr. Jim Sung, how are you? And
I'm good. Thank you.
congratulations for all this putting everything together. The northeast of Brazil, it's a very good place. And congratulations, Dr. Igor, Dr. Hildo Azevedo, and Dr. Wagner. Dr. Wagner, Max Wagner invited me today just to see you guys operating, and it's a beautiful setup. And yesterday I saw your presentations. Congratulations. And first of all, commenting Dr. Max Wagner case, I think it's a good case to do awake as well, but it is a child, so we need to see how the child it's gonna be into the operating room, and I believe they know the patients more than we know, of course. And a lot of childs will not cooperate. So I think it's okay to do under sleep, and children usually have more brain plasticity as well. So even if the patient awake with language problems, I believe it's a good chance of the patient to get better later. And commenting on the anatomy.
Craniotomy? Would you do awaken?
No, well, no. The youngest patient that we did awake was 16 years old, and the patient was okay during surgery. But this patient that Dr. Wagner has, it's 12. I believe it is the limit, right? Sometimes the
borderline, yeah.
Operate, yeah. So they know the patient. Some 12 years old might cooperate. But I think if they are not satisfied, if they are not okay with the setup, I think the patient can be asleep. And about neuroplasticity, the patient can get better later. It is a child, has more brain plasticity as well. So I think it's okay to do asleep. And if the patient awake with any language problems, it's a great chance to get better later. About anatomy that Dr. Jimson commented, we are from Brazil. Northeast is a big region of Brazil. They have amazing cities. They are talking from us from Campina Grande. It's a big city, but I don't know if they have neuronavigation. I'm from São Paulo. It's a bigger city, but we don't have neuronavigation in a lot of our hospitals as well. So we have to trust into anatomy. This is at the pars triangularis. I believe it's not that hard to find because in all surgeries, you're going to locate the Sylvian fissure, and it's just to go a little bit up. And the pars triangularis, it's usually a cisternal place when you have one enlargement of the Sylvian fissure. A lot of neurosurgeons are already familiar with the anatomy of that region. So I believe they can do a good job to locate the tumor based on anatomy. They can also do ultrasound. Dr. Igor, do you have experience with ultrasound, intraoperative ultrasound? And congratulations about your last night presentation about the pineal region tumors.
Well, thank you, Eduardo. It's a pleasure to have you here with us. And we don't use frequently the ultrasound. Sometimes when we have intraoperative neuronavigation, as you told, it brings some kind of comfort, let's say, let's put it that way. But we don't use ultrasound so frequently, except sometimes in deep lesions. So it might be helpful to see the final cleavage plan. I think that the Germans, they have a good experience with intraoperative ultrasound. And there is a nice discussion about ultrasound versus intraoperative MRI. And
stimulation.
Just about the brain plasticity, there is another thing that I would like to remark, that is the kind of lesion, the tumor type. It's probably a DNET, so it's a slow-growing tumor. And perhaps you can have sometimes when you awake,
this side or this
sometimes you have a negative mapping, let's put in that term. So the plasticity is already there because the tumor grows slowly and the plasticity goes with the tumor slow growing. So sometimes when you wake a child or adolescent, sometimes you have a negative mapping. So it's very important to consider also the kind of tumor that we are dealing, especially DNET. I don't know if you have any experience with ultrasound. I think that the main problem with ultrasound is that it's necessary to learn how to use it. I think that at least here we're not trained how to use ultrasound. It's a cheap tool, and it's available almost in every hospital. So I think that we need more training to start using more frequently. I don't know if you have used it frequently in São Paulo.
Well, we do have access to ultrasound and we have used it.
Professor Ma from Ningxia has an experience with ultrasound.
Can hear you.
I agree with you. I think ultrasound is a cheaper alternative to neuronavigation.
Neuronavigation, yeah.
Yeah, I agree. Ultrasound is very cheaper and very easier to use it because Dr. Jing Sung, they have the intraoperation MI. It's more perfectly, but for such kind of eyes, we use the ultrasound to affiliate it to the navigation. It's very useful. For this case, it's a pediatric case, pediatric little baby. It's difficult for wake. I think it's not. Don't try it. I think it's for a psychologist problem, and also have many troubles for pediatric. So I think don't use awakened anesthetics. That's my opinion. Thank you very much.
Try to make a strip. Try to make to localize the premotor cortex. We hope so. We can localize it just to illustrate how we can put this strip. And we have continuous talking with our Dr. Bruno. He's our neurophysiologist from here. He's from Campina Grande also. And he helped us in neuromonitoring. We, as a adjunctive resource, we have also fluorescein. I know it's a low-grade glioma, but we can try to see if it enhances the lesion. It's a tool that we have for. What is your opinion, Dr. Vinson, about the fluorescence for low-grade gliomas? Is it helpful?
Fluorescence?
Useful? Yes.
You mean 5-ALA or yellow?
Yellow.
Yellow. I don't think yellow is.
We use in Brazil fluorescent. 5-ALA is not allowed in our market.
Okay,
already.
understand.
Yeah.
So sometimes I will use fluorescent sodium yellow for high-grade glioma, but for low-grade glioma, I don't think it works.
Is it okay? Tá pegando?
Thank you very much.
It's okay.
In Brazil, in Brazil, we don't have our local FDA approval for 5-ALA, but sometimes they have on academic settings. So if you have one medical school and one academic institution, you might have access. So some people will use fluorescein. And I personally, I have never used, but some people comment that they are better when you have a break on the blood-brain barrier. So the fluorescein will get into the tumor if the barrier is looser. So I don't know what is the experience in low-grade gliomas. I think it's not a good experience. How is Dr. Wagner? Are you using fluorescein at that
yeah,
case?
we have fluorescein here because microscope is hybrid. We have ICG and fluorescein. So we try to use it.
Yeah.
Sometimes it's guide us in high-grade gliomas.
Yeah, I agree with Eduardo. If you have a low-grade gliomas, it's not going to be good. But if you have high-grade gliomas, you can use fluorescein. But there are two points. The first is the time in which you use the fluorescein. You might use it just before the craniotomy. This is the first thing. And the second thing, I guess, it's the dose of fluorescein. And for sure, if you have a break in the blood barrier, in the brain-blood barrier, it's gonna leak all around, and you might get a little bit lost, thinking that it is the glioma, but instead it's the white matter. So this is the disadvantage of fluorescein.
Igor.
Yeah, Jin
Igor, do you have any experience for metastasis lesion? I mean yellow.
I've never used it. Never used for metastasis. I only use it for high-grade gliomas and in the beginning for low-grade gliomas. And our microscope is not hybrid, so we adapt a dark light in order to amplify the fluorescent effect. Because we don't have an hybrid. Now we have a filter. We have a filter that we link it to the microscope lens, and sometimes it works, but sometimes not, because we need to remove it and look again and put it back and take it off. So it's not very comfortable. But sometimes we use an external beam light, dark light, so we can see the tumor.
We can try to find if it
can I insert myself in this discussion, please?
Professor Hildo, please.
Yes, I was one of the first who introduced the sodium fluorescein in Brazil because it's very cheap. You can find it everywhere. The eye surgeon, they use quite frequently. And 5-ALA, although it's not already permitted in Brazil, but it's about $500. It's absolutely impossible for us to use it. So I have used for metastasis, it's good. For GBM, it's very, very good. And for low-grade gliomas in adults, sometimes you can see some enhancement. So my experience, Igor has got more experience in children than me now. I used to operate on old children until 20 years ago, but now Igor is doing most of the children. But for adults, in low-grading glioma, you can see some loci of enhancement of yellow enhancement, and it does help. So I would not refrain myself from using fluorescein even in a pediatric patient, because just guessing that something could come out. But in adults, it come to be very helpful to me. Thank you.
We have these enhanced areas here. Maybe, we don't know if there could be a small contusion during the craniotomy or maybe some tumors. But you see that here's some enhancement area here. Yeah. But we don't know if it's tumoral, because we think that the area of the tumor is here. Yeah. Everyone agree, the audience?
Do you expose the Sylvian fissure just to be sure that you are above it? And can you see a little bit of Sylvian fissure?
Sylvian fissure. As we concentrate the craniotomy on the lesion, we spare to show it. Okay. But I think
and under clear light, the tumor appears to be a little bit whiter, right?
Yeah.
A little bit more pale. So yeah.
Yeah. It's limited.
And also with the sodium fluorescein, you don't have to to have a pinter or a more sophisticated microscope. You can go on. So it's very, very useful and cheap. But Eduardo mentioned the Sylvian fissure. I came from the vascular side. So I like to see the Sylvian fissure widely and beautifully shown in my patient. So I would show the Sylvian
was not
fissure.
so precise. We agree with you.
At least 1 inch. I would like to see at least 1.5 inches above the Sylvian fissure, and perhaps work out from the Sylvian fissure. I'll be, at least for me, I'll be on the safer way.
Yeah, we should expose more the temporal lobe. Yeah.
Yeah, I think it's just a way to locate yourself. Yeah. I think it's just a way to locate yourself. It's
yeah, sure.
But if you are comfortable with that, and it's okay. And just doctor, sorry.
With the stimulation that we have here on the premotor cortex area, our doctor of physiology, he showed that we are monitoring, and it's far away from the lesion. Okay, and you're gonna try to stimulate now to see if there is some language area. We begin to stimulate here. Wait a moment.
Can your neurophysiology tell us what is the setup for the stimulation? How many milliamps are you using? Is it monopolar, high frequency?
Quantos miliamperes você está usando para estimulação? 5 milliamperes for first.
With the train of 5 technique, with monopolar train of 5 technique?
Yes, monopolar. Yeah. Down, compress.
Dr. Igor, you were talking about ultrasound. Sorry, my connection was not that good. But we have experience with ultrasound. Ultrasound is very cheap. All centers will have ultrasound. So what you need to look for is for the transducer. What transducer is gonna help you with in brain tumors? So you want to look for something around 8 hertz, 8 hertz, 8 to 10. Maybe they have like 5 to 8, but everything that have this 8 in the middle is good. And you can see a little bit of the tumor. And we do have in our public hospital and in the private hospital as well. but it's good if you have the one that looks like a boot, like a shoe. Yeah, I think it's 7 to 11, something like this. But it's if you have the number 8 hertz in the middle, in the range, it's gonna look good. Do you use it, Dr. Jimson? Ultrasound?
Great to hear from you, because transducer is something very important. If you choose wrong, you're gonna have problems.
Yeah.
In this case, it might be useful, ultrasound for sure, but we don't have this tool.
Yeah. The transducer has a price, of course, but you can use it as many times as you want. So it's something that if you have a high number of cases, I think it is okay. And a lot of the transducers, they are not done for neurosurgery. They are done for other kinds of applications, but maybe you can try all the transducers you have and look for something. Look for something that have 8 hertz in the middle. Yeah.
To adapt, you need to adapt from other specialists. Yeah. That's true. Dr. Jinson,
yes.
Do you use ultrasound?
Definitely. Actually, I don't use ultrasound because in my operating room I have intraoperative MI. So ultrasound is not essential for my team. So Igor, can I give a short introduction of my case, and after that I shall scrub in the operation?
Yes,
because my fellow has finished the craniotomy.
Okay.
Can I share Marcos, the window? Is that okay? Marcos?
Oi, okay.
Is that okay?
No yeah, no problem.
So, Jin-san, go ahead.
Okay, thank you. So, distinguished guests, ladies and gentlemen, it's my privilege to give a brief introduction of my case. So today I will perform a weak craniotomy for a dominant side temporal insular low-grade glioma. This is a 38-year-old female, and the chief complaint is general seizure 1 month ago, and no other eventful. So preoperative physiological examination show normal. Everything is normal. But for the cognitive test, you can see in some degree, this lady suffer from neurological disorder in picture naming. So the Boston naming test show the score is only 19/30. So I believe for this case, the ventral stream, language stream was injured by the low-grade glioma invasion. Maybe the inferior longitudinal fasciculus or IFOF was invaded by the tumor lesion. So except naming, the other thing is good in the normal range. The KPS, the MMSE, and the aphasia battery of Chinese. The aphasia quotient is 94.9, and I think the score is in the normal range. So preoperative, this is the MI scan, T1 weighted image, and T2. So on the T2 image, you can see the lesion mainly located in the left side temporal. The lesion invaded in the anterior temporal lobe, the mesotemporal lobe, and the uncinate gyrus was invaded by the lesion. And the amygdala was also invaded by the tumor lesion, but behind the anterior silver point, I think the body of the hippocampus was relatively normal. So for this case, I prefer to preserve the body of the hippocampus and resect the amygdala until the anterior choroid point. And some lesion invaded into the insula, so you can see the external capsule was pushed inside beneath the lesion. This is the coronal image of T2 flare, and this is the sagittal image series. This is the T1 contrast image, coronal section and the sagittal section. Preoperative MI spectroscopy show the calling to an index. The maximum is 4.79. It indicates this lesion looks much likely a low-grade glioma. And the preoperative, we perform a functional MI scan. So when this case perform a picture naming task or undertake a hand gripping task, you can see the activation on the cortex. So the left side, the activation of the picture naming is close to the pars triangularis. So during operation, I will perform a language cortical mapping mostly here. This is the fiber tracking. You can see the motor pathway beneath, underneath the tumor lesion into the cerebral peduncle. This is the language fiber. We can 3D reconstruct the uncinate fasciculus, I4, superior longitudinal fasciculus, as well as the frontal arsenal tract. The inferior longitudinal fasciculus was invaded by the tumor lesion. As we mentioned before operation, the patient suffered from the neurological disorder in picture naming. So I think the I4 invasion by the lesion, by the tumor lesion, is the cause of the disorder in picture naming. This is another side, you can see the tumor lesion. So today I will perform a weak craniotomy. So my team, my colleagues has already finished the craniotomy. So after scrubbing, I will perform a language cortical mapping, including speech arrest, anomia, and alexia. So I think for this case, picture naming is very essential task during language cortical mapping.
Okay.
This is.
Can we continue here?
Yes.
Okay. So we have done the monitoring, and there is no functional area around the tumor, and you see that some enhancement of the fluorescence.
No, I don't think there is. Oh, sorry. This is Marco's voice.
Tell me, Marco.
Igor, I have finished the introduction.
Yes. Okay. Marcos, you can go ahead. Please share your screen with us.
Oh, it's not sharing? Diego, please, the microscope.
Now okay, now okay. Now okay.
And
so
Igor,
you can see.
I will scrub in, Igor.
Well,
and you can see that there are, can I begin to describe here?
Yeah, I think you can.
So there is some enhancement of the tumor. It's
just share the screen. Yes. Now
can you see now? Okay.
Yeah.
And there is some enhancement, you know. So there are some criticism about the fluorescence for low-grade glioma, but for us, as no neuronavigation, ultrasound, maybe it's a useful tool, as I said before. We did the monopolar stimulation. There is no functional area around. Okay, so we are quite calm and comfortable to reach and to extirpate the tumor. Dr. Luciano is the surgeon. He's trying to preserve this vein. Vein is important also. Young neurosurgeons have to have this lesson that veins are important, has its functional area of drainage of important functional areas of the brain. Yeah. Okay. He will. he will shut off the screen for 5 seconds just for technical reasons. The problem of fluorescence that sometimes it leaks to the tumor area. Sometimes it makes some trouble for you to decide which is tumor, which is normal. But you see, if we can change, or I will change now for the normal, it helps a lot. So it's an important tool in neurosurgery for us to use. Okay. I'm going to change again to the filter. For us, it's quite cheap. So it's easily found here in our local market, Brazilian one. As we try to preserve the vein, we do 2 entrance, 2 points of attack of the lesion. Igor, would you do a larger craniotomy or centered on the anatomical area? What is your opinion?
I always like to have some reliable landmarks. Yeah. So I think that I would have done a little bit larger, not too much larger, but just a little bit. Yeah. But you know, I guess that it's not something that's gonna change the course of the procedure.
I didn't know large surgery, you do a plan and during the surgery things change and you don't have the whole control. You know how difficult it is for us. And there is this factor also. You know.
Going great. Doing great.
Anyone from the panel can give out your opinion about what you do better than us. Feel free.
Excuse me, Marcos.
We are here to learn.
Excuse me. Can you hear me?
Yeah, I can hear you.
Oh, I'm from Yinchuan. I give you an introduction, my case, okay?
Yeah, okay.
Okay.
Marcos, we're gonna share for Yinchuan, okay?
Okay.
Yinchuan guys, go ahead, please.
Our operation plan changed because of patient's family disagreeing living broadcasting and some reasons. So today we resection the right parental lobe joint perinasal mini tumor. This is case presentation. Patient, 62-year-old male, chip complete. The left limb was weakness for 3 months. The patient had headache, no nausea and vomiting. Had MRI revealed the right parental lobe joint perinasal lesion. Physical examination, muscle stress on left side, grade 3, speech normal. Sensation on both sides normal. Biopsy skin sign negative. And medication history now. And past history, no remarkable history. This is MRI T1 weighted. We can see the lesion located right parental lobe.
Excuse me, Yinchuan, excuse me. We cannot see the images. We cannot see the images. Are you sharing the images with us?
Bruno, now we're going to try to make a subcortical mapping. We will stimulate underneath the tumor.
Oh, sorry. Wait for a moment.
No functional area, Bruno? No. How 5 amperes stimulation?
Okay, now Yinchuan.
Now it's 15 milliampere we are using for to try to make some spots.
Marcos, just a moment, please.
Okay.
Inchuan, now we can see your screen. Please go ahead.
Okay. 这能看到吗？ Oh, okay.
Oh, how cute.
Marcos, can you see it?
Okay.
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 This is T1. We can see the lesion location, the right parietal lobe. This is T2 weighted. We can see the surrounding the lesion has edema. This T2 flare, we can the edema. This is T1 contrast. We can see the lesion enhanced. Sagittal image. Coronal image. MRV revealed the sagittal sinus is normal. MRS shows the choline is high and NA is low. Revealed the lesion is benign. Function MRI. We can see the motor area next to the lesion. This is motor fiber tracking. CSA shows the tumor blood supply is occipital artery and superficial temporal artery. Through our plan, diagnosis right parietal lobe joint paranasal mini tumor. I finished.
Okay, thank you.
Okay, okay.
I hope all the best for you. Good luck in your case.
Okay, thank you.
What is the experience into functional MRI and meningiomas? Do the meningioma that has a lot of vascularization, does it disturb the functional MRI, or do you have a good answer for the functional? Do you trust the functional MRI meningiomas?
In each one, do you have intra-op MRI? Or just in Shanghai and Igor?
Inchuan,
okay.
Guys, are you online?
Okay, okay.
Do you have
right.
functional MRI?
Yes. 我咋共享不了？那行了，来，
Simulate for different.
不是我这个为什么共享？我共享屏幕啊，他想看那个，对，他想看那个，对。This is contrast. Okay.
Bruno, simulation. Igor, can you hear me? Is it okay?
Yeah, we can hear you, but we are now seeing the Inchuan screen.
Okay. But can you see the surgery here? Okay.
No, Inchuan needs to stop sharing, and then we can get back for you.
Oh, okay. Stop 这个共享 ，stop 共享。
好了。
把共享关了。 关了啊。
Okay, Marcos, you can share your screen now, I guess.
Diego.
We can see you. Okay.
Yeah. The microscope. We're stimulating the region that's supposed to be near the Broca area, the premotor language area. So there is no stimulation, so it is still spared, not lesion. No damage to the Broca area. Can you say that, Bruno? Our physiology? Yes. So we are more, as always, we're comfortable to deal with sumo.
But do you
Diego,
have
do you
needles? Do you have needles at the vocal cord, or how do?
The what?
Do you have needles at the vocal cord to map
Yes,
motor function? Yes. Okay.
Bruno, what did you monitoring the voice, the language? There is one electrode on the tongue. Electrode na língua, tem? No. There is just on face. In this case, just on face. No, nenhum na língua, nada. No.
Okay.
No vocal cord stimulation.
Okay. And you're using 5 milliamps still? Everything with 5 milliamps?
15 we reach.
15. Okay.
Yeah. 15, Bruno? 15? Yeah.
So, just for the audience, as the more milliamps you use, the bigger is the field that you are stimulating. So if you don't have any answer with 15 milliamps, most people will agree that you don't have motor essential areas into 15 millimeters from the stimulation, right?
Yeah. When Shanghai wants to get the screen, feel free, okay? I think our objective is already done. Feel free to, easily suctionable tumor.
Right now, they're setting up, the microscope is being set up. That is why the screen is not being shared. It will be
Eduardo, do you think that this enhancement area of fluorescence is some tumor?
Well, Dr. Wagner, I don't have experience with fluorescein. I know it's a good option because, as Professor Yudo told, it's cheap, it's available, it's safe. I think it's good to use, but I don't personally have experience. I don't know because probably you have more enhancement in the middle of the tumor because it's more neoplastic and everything, but into the board, the margin of the tumor between the tumor and the brain. Do you see some enhancement, or it's the most difficult part, right, to understand where the tumor finishes?
Yeah. We used to instill in the patient just before the anesthesia. Okay, it's different from vascular.
ICG, yes.
ICG is different.
It's good. It is good to use, yes.
Yeah, good one too.
Yeah. So, was the tumor homogeneous, or could you see some heterogeneous?
It's homogeneous.
我的耳麦没打开啊，我听得到，但是我不能说话呀。你不是要帮我按一下吗？上面。
Dr. Wagner, did you have any positive regions into the stimulation, or everything was negative?
No. Negative. Bruno,
everything.
No, nenhum sinal, né? Captou tudo
好，我们
certo,
开始
né?
数刺激器。
Yeah. all silent areas.
单体，
Okay.
单体，我要双体。
And motor potential also is
电极片先给我。
okay.
So besides mapping, you are also doing monitoring, right? You are monitoring motor functional online all the time.
对的，不是这样的。
Yeah. And no damage, the potential keeps flowing normal.
不要急，不要急，都可以上。你问一下徐耿，帮他看一下电极，插的对吗？
对。
For public patients, it's easy for you in São Paulo to have it.
1对1，6对6。
This support?
You mean fluorescein?
No. Monitoring, neuromonitoring.
Monitoring, well, depends. I'm from the University of São Paulo. It's a big public space, a big public institution. We do have, not every day, but once or twice a week, we can have a neuromonitoring team. But it's not available everywhere, right? So into public hospitals, it's harder. Into private, it's easier. But I think it's a great tool. I think it's better than any other tool that you can use. Neuromonitoring team, it's essential. It's very good for low-grade gliomas.
Yes.
Very good. Do you have functional MRI, Dr. Wagner, at Campina Grande, or it's hard?
We have, but it's, not easily to use in public patients, you know.
Yeah.
The software is not easily find.
Yeah. Because
do this corticectomy in 2 places? So just
right-hand sided or left-hand sided to right?
Igor.
Do you know?
Can you hear me, Igor?
Yeah, I'm here. I can hear you.
Would you use this 2 holes technique, or everyone agrees with this technique that we used, preserving the venous?
Lateral mapping.
Yeah, I do agree. Yeah.
双体刺激器。好，1.5毫安啊。我的声音他们听得到吗 ？So can you hear me, Igor?
Can hear you clear.
Yeah. So now after dural opening, you can see this is the Sylvian fissure, and here is the anterior silver point. So this might be the triangle, pars triangularis. This is the horizontal ramus. This is the ascending ramus of the Sylvian fissure, and this part might be pars opercularis, and here is the ventral presentral gyrus. So you can see here is a U-turn, as Dr. Ribas always said. This is a beautiful U-turn connected the pars triangularis, pars opercularis and the presentral gyrus. So the Sylvian fissure through the arachnoid membrane, you can see the grayish tumor lesion here. So of course, here is some bleeding in the subarachnoid membrane space. Now I want to perform cortical mapping for language. So typically, I will start the stimulation power from 1.5 milliampere. The maximum value is 4 to 6 milliampere. Now I start from the 1.5. 大概我们开始啊，让他数数。This patient was asked to counting from 1 to 50. 数数好吗？ Okay. Now, when I put the bipolar stimulator here, you can see the patient stop counting. So I think here is a positive reaction for cortical mapping. 一，给我呀，没有一啊，随便选一个字母给我都可以。你随便给我个数字，不要另外选了。你比我还紧张干啥呢？又不看你脸。Here the first positive site. 双击擦干净。来，我们继续啊 ，Let's continue. (4D7)
Dr. Jimson, it's a small craniotomy. Usually do small, or do you do very big, or
you mean the extension of craniotomy?
Exposure, yes.
Yeah. This is a typical exposure for insular.
You didn't go behind the ear line. It's everything anterior to the ear line.
I think it's enough. You can resect the tumor. After make a fistula, you can through the corridor from anterior to posterior. So I think the extension of exposure is enough. 来，继续手术。
Aí como é que tá? Tá legal? Outra coisa, aqui tá com pouca potência. Pouca potência. Acho que meu microfone você pode desligar um pouco, para não dar interferência na aula lá de Xangai. Quando eu pedir, eu falo.
好，稍微等一会儿，来，枪上念名交来一点。一点点，太大了。好，第二个图片命名，给个镜头，这个玩意儿。4D7，塑料薄膜剪好了吗？好，开始啊！再来，他什么反应？对的啊。好，好，再来。
Jinsan, can you hear me?
Yes.
Could you tell Could you tell us a little bit more about the patient positioning?
Oh, the supine position and the head rotate to 45 degree to the contralateral side, and a roll will put inside under the shoulder, under the left shoulder. So this is a typical site for insular. Now I perform the picture naming. So on the screen you can see the patient will request to perform a picture naming task.
Yeah, we can see it. We can see it.
How many milliamps are you using, Professor Jimson?
1.5 milliamp.
It's very, very low.
Yes, very low.
So the risk of seizure is very low also, very, very low.
Yes, to my experience, the general seizure during brain mapping is about 5%.
That's good. Very good.
And do you also use cold saline?
Yeah, cold saline. Yes, I prepared the cold saline. Ice the saline.
Yeah.
Very cold.对吗？喝点水。冰水。Now I increase the current to 2.0 milliamp. 2哦 ，OK， 再来继续。3。
这张图片是袜子，这张图片是鞋，这张图片是裤子，这张图片是帽子。
Coloca a imagem do professor Ginson para eu ver a imagem do quê?
这张图片是老鼠，这张图片是兔子，
Não acho.
这张图片是猪，这张图片是猫，这张图片是鸡，这张图片是狗，这张图片是鱼，这张图片是马，这张图片是树叶。
好，看文字。
这张图片是苹果。
各个词汇是什么？
这个词汇是人，这个词汇是面包，这个词汇是书本，这个词汇是工作，这个词汇是足球，这个词汇是学习， 这个词汇是旅游，这个词汇是挖掘，这个词汇是攀登，这个词汇是手术，这个词汇是勤奋，这个词汇是勇敢，这个词汇是咖啡，这个词汇是大海，这个词汇是城市，这个词汇是规定，
嗯哼，好了，
这个词汇是森林。
好，接下来我们休息一下。桶里的水吸掉了。
这个词汇是医生。
好，可以了，可以了。休息。So, in conclusion, for the whole process of cortical mapping, language cortical mapping, you can see this is the anterior silver point, ascending ramus. Here is the pars triangularis, pars opercularis. So, positive site 1, 2 responsible for speech arrest. Positive site 3 is corresponding to the anomia. So one suspected region for anomia is the superior temporal gyrus, but today it's much safe. And another suspected region for picture naming, I think, is pars triangularis here. But today is also a safe zone. So my plan is resect the anterior temporal lobe to gross total resect the anterior temporal lobe and expose the temporal stem, expose the temporal horn of the lateral ventricle, to expose the hippocampus as well as the amygdala. So, and after that, I will make a short, small cortical incision on the surface of the pars triangularis to expose the short gyri of the insula and the anterior limiting circus of the insula. So let's start. 帮我耳麦关掉好了。
Jin-san, can you hear me?
帮我耳麦打开。床头上半身放下来，放平。Yes, yes, I can hear you. Eagle.
Yeah.
Okay.
Great job in the mapping. So you're gonna perform a lobectomy first, and almost a full temporal lobectomy, and then you're gonna do a corticectomy.
Yes, almost full temporal lobectomy, but except the mesostructure of the temporal lobe. I mean the hippocampus and the hippocampus, the body of the hippocampus, I will spare.
Yeah. We're gonna have a break with you and gonna get back to Marcos. Okay?
Okay.
Just a minute, because I can see that he's already almost finishing his surgery, okay?
Okay, I will be back.
And then we get back with you, okay?
Yeah.
So one question, Jin-san, will you gonna use intra-op MRI in this case?
Yes.
Okay. So Igor, can I have the screen?
Go ahead, Marcos. Share your screen, please.
Agora pela upload da minha. Okay. So we preserved.
帮我耳麦关掉好了啊。
We preserved the venous. We're almost at the end, microscopically. We're gonna change.
Just a moment, Marcos. Just a moment. Jin-san, you need to stop sharing your screen a little bit, so Marcos can get in. Okay.
Yeah. Can you hear me, Igor?
I can hear you, but we can't see you.
He cannot see me.
Jin-san, can you hear me?
Ele não está vendo você?
É
você se posiciona em frente àquela
Não,
câmera.
Xangá, lá. A nossa tela não está aparecendo, não.
Jin-san, can you hear me?
Can you see my screen, Igor? The microscope?
No
microscope? Mm-hmm.
We will only be able to see your screen as soon as Jin-san stops sharing his screen.
Okay.
Otherwise, you're gonna keep watching the Chinese.
But you can see here. You can.
Now okay.
Okay.
Thank you, Jin-san. Thank you. Marcos, go ahead.
We are almost at the end. And I want to speak in Portuguese for our audience a little bit because there are someone that doesn't understand. Okay? Let's gonna give 5 minutes in Portuguese. Okay, Igor? Vamos explicar um pouco a discussão que a gente fez em português para o pessoal, né? Desse caso, a gente encerra, tá bom? Então, pessoal, esse é um caso de um glioma, né, de baixo grau. A gente fez uma ressonância e identificamos, né, uma criança de 12 anos, um adolescente. Então, a gente optou por fazer uma ressecção, uma craniotomia. A ideia seria uma craniotomia pterional, mas na hora a gente mudou de plano, centralizamos mais frontal mesmo. Mas foi discutido, o ideal também seria expor a fissura silviana, mas como é uma criança lado esquerdo, nós quisemos fazer minimamente invasiva no sentido de reduzir danos, né? Reduzir um pouco de danos. Mas a gente sabe que quanto mais landmarks, quanto mais referências que nós tivermos, mais seguro fica a ressecção. É uma lesão relativamente fácil, né? Mas apesar disso, a gente teve todo o cuidado de usar a monitorização transoperatória. Nós começamos com estimulação de 5 Hz, porque o paciente não está entubado, e isso nos dá uma segurança para aumentar um pouco essa estimulação sem risco de crise convulsiva, né? Então, ela foi monitorizada e estimulada. Nós fizemos um mapeamento cortical e subcortical e nenhuma área foi reconhecida, área funcionalmente importante, como a área pré-motora, córtex pré-motor, como a área da linguagem, Broca principalmente, que estaria acometida nessa região. E com isso a gente fez a ressecção em 2 locais, em 2 entradas no córtex, para preservar essa veia en passant que passa, né, pelo vaso. A gente vai tentar ao máximo preservar. E a gente usou também fluoresceína, que no Brasil é mais fácil de usar, não é tão caro, né? Esse paciente é um paciente do sistema público de saúde. A gente usou e a gente acha que ajuda um pouco, já que a gente às vezes não tem neuronavegador disponível, né? Então é mais uma arma que nos dá uma ideia de onde está a lesão e a maior potencial de ressecabilidade. É uma lesão que potencialmente pode ser curável, na hipótese diagnóstica também pode ser um DNET, além de low grade, tá? A gente evita, às vezes, coagular o máximo possível, porque é nessa coagulação que você lesa alguns tratos importantes que estariam envolvidos nessa região, como o I4F, que é o fascículo I4F, traduz, Eduardo, é o fascículo
fascículo fronto-occipital inferior.
Fronto-occipital inferior e o fascículo inferior, que são importantes nessa região, né, que está relacionado com a cognição, é uma grande via de conexão cerebral. Uma grande highway, vamos dizer assim, né? Então a gente usa, para você ver, a gente vai mudar aqui um pouco, né, vai sair da fluorescência, vai passar para a luz normal.
Marcos.
Pois não? Ok.
Se você puder compartilhar a imagem do microscópio, a gente está vendo só a sala. Se você puder botar
a imagem do macroscópio. O microscópio não está aparecendo.
Tem que selecionar,
mas para a gente está aparecendo, Igor.
A gente só consegue ver aqui, a gente não consegue ver a imagem da câmera do micro, só consegue ver vocês aí na sala.
Mas aqui a gente está vendo tudo. Você clica nela e seleciona ela, entendeu?
Eduardo, você consegue ver a microscopia ou só a sala?
Não está vendo a microscopia. Um momento, nosso auxílio técnico aqui tá mostrando.
Não, mas acho que sim, ó, o Brasil Microscope, tô vendo sim.
É isso aí,
vendo.
Isso aí, é.
Então,
Brasil Microscope.
Você consegue compartilhar essa tela?
Eu acho que ela ele tá como como se fosse
um palestrante,
uma pessoa,
um canal,
assim.
né?
Um canal, um usuário.
Exatamente. Aí você seleciona, ela fica como tela central. Né?
Ok.
Estou vendo a visão do microscópio, não.
Tem que selecionar, doutor, apertar nele.
Olha que as conexões ali.
Doutor Hildo, é só clicar 2 vezes em cima na janela, onde está escrito Brasil Microscope.
Ok, obrigado.
Vou mudar um pouco a tela de fluorescência para ver se acrescenta alguma coisa nessa nossa ressecção. Lá no HR vocês usam, né, a fluoresceína, no Hospital da Restauração? Vocês têm acesso?
Usamos a fluoresceína.
Uhum. Aumentar a luz. Então, quando a gente muda o filtro, às vezes você tem que aumentar a potência da luz para realçar melhor. Isso é um detalhe técnico que a gente ficou vendo. Aqui no nosso centro cirúrgico, a gente usa essa luz de teto, né, que dá uma calmaria, mesmo nos momentos de mais dificuldade. Né? Então, aqui é a base do crânio, né? Vê que o cérebro está mais flácido agora.
Dr. Wagner, gostei dessa sua abordagem. Você já comentou, né? Mas que você fez janelas e preservou as estruturas vasculares que estão sobre o córtex, né? Principalmente as veias, para permitir a drenagem das outras regiões, né? Só para comentar, deve ter vários alunos assistindo. Geralmente as pessoas tiram um bloco ou uma região inteira, mas você fez janelas e acabou esvaziando a região com o tumor e preservou a drenagem venosa. Uma abordagem bonita.
A gente vai tentar rodar o ICD para ver se ele consegue mostrar alguma coisa arterial, não sei se venoso. Você pode ver um pouco a drenagem venosa, né? Uma pola do ICD. A gente pode usar, na verdade, vários canais de trabalho, né? 2, 3, 4, sempre procurar preservar os vasos de passagem, né? Quanto menos invasivo a gente for, melhor para o paciente. A gente sabe que o paciente jovem tem mais capacidade de restauração, mas sempre o cuidado, né? Aqui, Bruno, com relação à nossa monitorização, está tudo certo aí? Nenhum distúrbio, nada, né? Monitorização contínua do córtex pré-motor, preservada, sem nenhuma baixa de potencial. Vamos tentar fazer.
Excelente, Marcos. Marcos, consegue me ouvir?
Ok, I can hear you.
Podemos voltar agora para o Ginson?
Ok, fica à vontade.
A gente vai ficar alternando um pouquinho.
Finalmente, agradecer aí a todos.
A gente vai alternar um pouquinho e...
Ok, precisa voltar.
Mas excelente, muito boa. Parabéns a todos os colegas aí de Campina Grande.
Ok.
Por todo o esforço e pela destreza na técnica. Nós que agradecemos.
Obrigado.
Parabéns, Marcos. Parabéns, Luciano. Vocês estão muito de parabéns. Muito orgulhoso.
Obrigado. Vamos melhorar, sempre para melhorar.
Obrigado, amigos.
Parabéns, Dr. Wagner. Parabéns, equipe. Bonito aí o caso. Parabéns.
Obrigado.
So we're gonna change to the English. Dr. Jinson, can you hear me?
Hello, I can hear you.
Dr. Jinson, can you hear me?
Yes, I can hear you.
So please, you can share your screen with us.
Oh, OK. 把我们那个视频下读数。Can you see it? Hello?
Yes, I can hear you.
Yes, I can hear you.
他刚才找我们。
能看见，但是不能放到主屏幕上。
I think it's easier to double click in the window. Washan.
对对对。
He's currently just dissecting the tumor, but he doesn't have a microphone on him. Can you hear me?
Can hear you.
Yeah, yes. So just using the CUSA aspirator to resect.
Okay, we can see it. Eduardo, can you see? Professor Hildo, can you see?
If I go to multiple screens, if you go to the layout that you can see multiple screens, you can see Huashan. And then you can select it.
Yes.
Double click, see multiple people, multiple screens, and then select.
Just go to Huashan window and double click. Okay, there is no microphone for Jinsan, but we can see he's using the CUSA.
He's using the CUSA below the Sylvan Fisher, so he's working on the temporal lobe. And as he said, the first step of his surgery will be to remove the temporal pole and maybe to see the temporal horn, and then later go to the temporal mesial structures. I think this is gonna. What did you understand, Igor? Is something like this?
Same thing.
Yeah.
Same thing. I think that this is that's his surgical plan. He wants to preserve the mesial structures.
I was telling him that it's a small craniotomy. We are used to make a larger exposure.
Yes.
How is your Professor Hildo? Nice to see you. How do you prefer? Do you prefer to open small or big, or do you have any?
Well, I think that for tumors, the goal is not to do a so-called limited craniotomy. It's just to expose a good area for you to get hold of the anatomy. And I like to see the Sylvan Fisher in those cases. So I will do somehow an extended pterional craniotomy for this patient. I'll show the 5 or 6 centimeters of the temporal lobe and 1.5 inch above the Sylvan Fisher. Yeah.
Yeah, I agree. It's a small craniotomy. I agree.
But for sure, he has a lot of experience. So
yes, we are prone to do larger craniotomies, but as you said, it's the experience.
So how can I see Yuashan surgery? He used the CUSA in the temporal lobe, but I cannot enlarge the picture. Also, I'm not allowed to enlarge the picture.
Just double click, Professor. Double click.
I did it.
Did you do it?
No.
You just select the window and double click.
Dr. Hildo, I had to go on the small window of Huashan and choose to fixate. I don't know how is the name in English. Here say fixar video. And then I go and see just one screen and I can see them big.
Fixar video, yes, Eduardo.
Fixar video. Did
Valeu.
it work?
Thank you,
yes.
Oh, yes, fine. Absolutely fantastic. Thank you.
So he's using the CUSA. As you see, the brain itself does not bleed a lot. Some people, you can go fast. He's going fast, and he's resecting all these neocortex. He's not. I think he didn't reach the temporal horn still. So I think he just removed a big piece of the lateral temporal lobe, and now he's going more deep and more inferior as well. And the brain bleeds, but it's not a lot. It's a normal brain.
Igor loves CUSA very much more than I do, but
Yeah.
it is also I'll be using CUSA. But my boss used to say, my mentor, the most dangerous apparatus. And once I did ask Professor Yashgill, how do you know, how could you stop removing the tumor? How can you delineate the boundary? And he said, through the sound of my aspirator. So I said, Professor, then I'll stop here. I can follow you. So that's what Professor Yashgill told me. Apart from mentioning the most lateral lenticular straight artery, of course. But he said that he loved to use the aspirator because he could hear the sound of the aspirator in order to delineate when to stop.
I do like CUSA, but I might say that I used to use more. Nowadays, I use less. But it is a nice tool. Properly use it, it is a nice tool. Let's see if they can hear us. Jin-san, can you hear us?
No, he doesn't. He doesn't have the microphone on him, so he cannot hear you.
Mute. It's mute.
Yes, it is muted.
Okay. Okay, I can hear you. Can you hear me?
Jin-san or Inchuan?
Yinchuan.
Inchuan, yes, Inchuan.
Yes, Yinchuan.
How things going right now with you?
We have already explored the tumor.
Okay.
Yes. And continue blocking up the blood supply of the tumor.
Okay, we can see it.
Yes.
Igor, can you hear me?
Yeah.
You see the total preservation of the vessel. It's our main objective, you know. We did an ICG here, and it enhances all the vasculature, preserving the vessel across the tumor, okay?
Trying to see your camera. Yes, we can see the microscope.
So the ICG is, okay, preservation of the vessel, okay?
Great job.
Yeah, thank you.
Great job, my friend.
Thank you. Yeah, good. The ICG is a little bit expensive in comparison to fluorescence, but for brain aneurysm and these tumors, we also use to have a parameter in the beginning and after the resection of the tumor to see which vessel we preserved. And it's information for us to predict any post-op ischemic damage, okay? We can use also in tumors. Okay, Igor? Can you hear me?
Yes, I can hear you.
Eduardo,
Yeah.
Do you use, Eduardo, ICG for tumors when it's possible? Eduardo?
Yes, well, no, not a lot. We use more for vascular lesions, like aneurysm or EVMs, but not for tumors. But I think it can be a good idea. I think I'm not against, but I have not used. Have you used, Igor? Or Professor Hildo, have you used for tumors or?
Never used.
Never used it.
Professor Jimsong is operating an insular tumor. I think one of good question would be, did he do angiography test before? Because if the lenticulostriate arteries, are they displaced medially and he can work safely into the tumor, or are they not? Are they inside the tumor? I think this question is a good question, but I don't think if he did an angiography test, but it's.
We're gonna show you, our screen was not sharing. Now we're gonna show you the ICG.
ICG is very safe as well. I think it's not a problem. If you want to use, it's okay to use.
Yeah. But in terms of cost, you know, we have to think about it. Can you see the ICG now?
Yes, we can see it.
Yes, okay. Now, so it's preserved, the vessel, en passage. Yazagil call it en passage vessel. Do you know this nomination for this? In AVM, it's en passage. Yeah. So it's well preserved. All the vasculature.
Yes, we can clearly see this.
Yes.
Clearly see this.
Yeah.
Beautiful, very nice, nice.
Yes, yes, thank you. Because you can see the image turns up, but we don't know for sure if it is preserved or not anatomically. Yeah. So for tumors, it's useful also to predict the post-op deficit. If you coagulate lots of vessels, it can give some ischemic damage and post-op results. And for vascular, it's already useful. Everyone knows. So we may use before to deal with the tumor to see how is the vessels, and then after the resection to make a comparison between before and after.
Well,
very nice. I think it's a good idea. It seems like a vein, not an artery. Like yes, Professor Dr. Wagner. Yes.
Yes, it's a vessel. It's a vein.
It's a vein. Yeah. Okay.
Yeah.
Okay.
Vamos fechar?
Okay, I guess that Inch 1 is already debulking the tumor. Am I right?
Yes, I have already explored.
I think, Igor, they are dealing with the vessel. They are trying to preserve this vein.
Yeah, it seems, yes.
They are having trouble with the vein. Not trouble, I mean, they are just doing a very elegant and detailed work to preserve this vein. And Dr. Jim Song in Huashan, he's still working with the CUSA, and he's almost reaching the temporal base, right? Let's see.
Yes, I guess so. It's very, very deep now, huh?
Very deep. I think he's looking for the temporal base now, just to be sure that he already removed the temporal pole. He might be looking for the base. What do you think? Maybe that's dura mater. That's the temporal base.
That's the dura from the base. Yeah.
Okay,
we can clearly see now.
Yeah.
That's the dura.
Yeah, now for sure he's at the most basal aspect of the temporal lobe, the temporal pole, and he's gonna resect that region. It's interesting because he did a small craniotomy, but he's gonna resect this, and with this resection, he's gonna gain space, and he's gonna get the other regions as well.
He's trying to build a corridor, so it's fast. It's going fast.
I don't think that it's such a small, because perhaps he's demonstrate at least 5 centimeters from the temporal pole.
Yeah. Okay, Inch 1, would you like to do any comments, any remarks right now?
Yes, I'm here.
Please go ahead.
Right now, the section arachnoid planes and protect the draining vein.
Yes, we can see there's a lot of veins.
Yes.
Yeah.
And I think the tumor is rich blood supply.
Okay.
Yes.
So you are addressing first the vascular supply and the drainage before getting into the tumor?
Yes.
That's the strategy?
Professor Jinjong, please. Is the patient sleeping now? How is this anesthetic situation?
Yes, the patient is asleep right now. He's under general anesthesia.
Okay.
Did you have to put a laryngeal mask again, or he's just breathing with
through the nasal? There is nasal cannula inside. That is what is used. Yeah.
And it's comfortable.
Yes. Yes. This is what is used here.
Because it's good. The brain is not stuffed. It's not. It's very. It is not stuffed with a lot of CO2. I think it's a good anesthesia. It's good.
The brain is not angry.
It's a friendly brain. Friendly brain.
That's how my old professor used to name it.
Dr. Jinson, any comments, any remarks? I guess he's on mute now, huh?
He is currently operating on the temporal lobe, and I think after he has resected, when he will give a brief overview of what he has done. So right now he doesn't have a microphone on him.
Okay, great. Thank you.
But we can see that now he's dealing really with the temporal pole.
Yes, that's right.
Resect the middle region, and now he's going a little bit more anterior to resect the pole underneath the craniotomy limit, right?
Yes, that's right.
Let's discuss a little bit about corticosteroid. Corticosteroid. Do you use how many days pre-op? How will you deal with this drug, corticosteroid, dexamethasone?
Well, for low-grade tumors, if you don't have brain edema, I think that it's not necessary to do pre-operatively, okay? So, but we use...
operate a case like this without corticosteroid?
We do intra-op doses, but not pre-operatively. We use intra-op attack dose, and then we keep it for 3-4 days up to the peak of edema, and then if the patient's okay, there's no big edema in the postoperative scans, so we can start to reduce the dose. It's a little bit different for mass effect lesions such as high-grade gliomas, but too much corticosteroids might be dangerous, especially if you use it for a long period of time before surgery.
Yeah. Here we try to use gel foam below the dura, because if it's a recurrence of the tumor, it's easily for you to detach the dura. Do you know this technique also?
Well, when we have gel foam available, we also use it.
Yeah. It makes easily reoperation. I hope you don't have necessity in this case, but who knows?
I don't think it would be necessary.
Yeah, and the life expectancy of a patient like this, what is your opinion about? How many years?
Well, if you can achieve when you achieve a gross total resection for a DNET, you have a good outcome, and the rates of recurrence are very low for DNETs.
So
do you agree, Eduardo?
I agree. It's not the first location for a DNET, right, Igor, is usually temporomesial lesions, and they usually have a more multiple cysts lesion you can see in the MRI. But it might be a DNET because it's a very young patient. And did the patient have seizures before or no seizures? Do you know, Igor? I don't know.
I think it was
the grand mal seizure. That's one grand mal seizure.
Okay.
Only one.
Yeah.
Only one. Yeah.
But if it's a low-grading glioma, of course, depends on the cytomolecular study. But for being a low-grading glioma, providing you don't do a total resection, the outcome in a long-term follow-up, it's some worrisome, you know.
And antiepileptic drugs, how long would you use? 5 years?
Well,
or
if the patient's got a fit before the operation, so it should be maintained. If it not, no reason for using. And
how long?
Also, he had a fit, so you need to keep on with the anticonvulsants. But in the literature, there is no unanimity. So some people use for 3 months, some people use for 6 months, some people use for 1 year. So there is no,
nobody knows.
Yes, very strict guideline about that. It's an open issue.
Any opinion about the drug?
Well, I think that today, levetiracetam is the best because just in case you need to do them some chemotherapy, because if you have a co-deletion of 1p 19q, so you need to sometimes you need to give some chemotherapy. So, but of course also the future, the outcome needs to see whether he's got a IDH mutation or if it's something worse than that. You know?
Yeah, I agree. I think if the patient's been operated asleep, it's very hard to do a very radical resection. It's left temporal frontal lobe. I think it was a good resection. I would be afraid of doing like a very big resection for the deficits. I think they did a good job. And I saw some people closing with gel form. I'm not doing this, but some people will do it, and they claim that if you need to reoperate the patient, the dura will not be attached to the surface of the brain. It will be easily to just open the dura and reoperate the patient.
Yes, this is the opinion of Marcus. This is the opinion of Marcus. I don't do that. Just for this indication.
I think that one of the problems with gel form is if you use it in small places, because it's going to expand in the immediate postoperative period. Not in this case for closure, but if you use gel form in, for example, in spinal cord tumors, sometimes you can have an induced mass effect due to the expansion of gel form.
Yeah, I saw
it's a problem for post-op MRI. It can mismatch the results.
Yes, also.
And like an artifact, yeah.
Everything that you put in the brain might be an artifact.
Sure.
So go, Eduardo.
I saw Dr. Ugur Ture saying that he uses, in a congress as well, in a lecture, that he uses gel foam as well. But just as Igor said, he's afraid of this mass effect of this enlarging when it sucks the blood. So he's gonna just use one layer of gel foam. I think you can detach the gel foam into 2 layers, and he's gonna just use one layer.
Yeah, we divide in the middle. We divide in the middle and then use one piece. Yeah, we don't use the whole gel foam, you know. We divide.
Yeah. Okay.
Fora de foco a câmera. A câmera tá fora de foco. Abre um pouquinho.
So let's see. Inchuan.
I think Inchuan they don't have audio, maybe. Intro
No,
audio.
Inchuan they have audio. Huashan, Jinsang doesn't have audio.
I'm trying to hear, yeah.
Yes.
Maybe he's concentrated on the resection.
Yeah, I think so.
Inchuan is still dealing with the vein. Very difficult vein there.
Yeah. That's the problem of live surgery. You don't know what you will expect. Yeah.
Well, they're doing great. Great job. They are already dissecting. Found a cleavage plane, I guess.
That's going to do here in Brazil more webinars like this with live surgeries and sharing experience. It's good for us, especially for remote cities like Campina Grande, that's far away from university centers. We want to have more up-to-date knowledge from you from big centers.
Yeah, very good idea. It's and the image is very nice. It's very good image. I believe people are enjoying it. A lot of people are writing to me that the image is good, the technology, people are at home just having dinner. A very good way to learn. Congratulations for the Society of China and Northeast Brazil. Very nice.
I think that the first time we have this kind of webinars with live surgery. Can
Probably,
you say that?
yes.
The first, in Brazil it is.
What do you know, Professor Hildo? You're more...
Oh, yes, I think that for teaching and to help people learning and the young neurosurgeons is our duty. I'm very pleased just to help whatever I can. I think it's, I did learn a lot these days with these webinars, and I'm enjoying the operation. I love to see microsurgery. But let me do a bit of trade-off. And Campina Grande, in a couple of years, I'm sure that we have one of the best hospitals in the northeast of Brazil. It's named HELP. It will be a tremendous university academic hospital that it will be under the sponsorship of a university that named Unifacisa. So don't think that Campina Grande won't be in the hidden behind the neurosurgical map.
Yeah, thank you.
It will be a fantastic hospital. You can be sure.
Yeah, and we have here also Melody. Melody is a Brazilian Chinese hybrid medical student. Can you say the impression of the Chinese people that you get in touch, Melody? Eles estão gostando do evento, Melody?
Nossa, estão amando.
Gostando mesmo?
Imagens muito boas. Você quer que eu pergunte agora ou o que me falaram?
Eu achei que essa garota fosse da China, mas agora eu vi que é brasileira.
É meio do Brasil.
Oi, todo mundo, eu sou a Melody. Eu estou fazendo medicina na Faculdade de Medicina de Jundiaí. Prazer conhecer todo mundo.
E ela fala com sotaque paulista, não? Paulista.
Parabéns para quem não conhece.
I think these links between Campina Grande, not only through your private hospital, Marcus Wagner, but also through this university, we can increase the links with the Shanghai also University. I'm sure that the principal of the university will be very pleased also to establish these links. He's going to have a very strong links with the Johns Hopkins Hospital in Baltimore. But anyhow, nothing impedes that another Asia, no? But it's I'm not marketing, but
Yeah.
Campina Grande will be very well served in a couple of years.
So just for people to see, we in Brazil, we have a very diverse community, a lot of people from everywhere because we had a lot of immigrants. And this girl that's going to talk, your family is from China or Japan?
China,
My family
Taiwan.
is from China.
China, that's great, that's great. So we have a very big Chinese community, right?
Yes, really big, really big.
Very big. You are the second generation in Brazil, first generation?
Yes, I'm the second generation. That's the one of the reasons I know how to speak Chinese. We are a really traditional Chinese family.
A very beautiful language, very beautiful.
Thank you so much. Just as Portuguese, Brazilian Portuguese is a really beautiful language too.
Which one is more difficult?
Brazilian grammar is probably more difficult. Brazilian grammar is a lot more difficult, but the writing is Chinese.
But imagine the problem of Professor Jin Song to monitoring these patients, because the language is also difficult to manage in the Chinese language, don't you think, Melody? The Chinese language for you to monitor during surgery is different from Occidentals, because their area of language is not located just in one area, in one spot. It is spread around the brain. It's different from Occidental ones that language area stays just in one area. So it's different between us.
What I gather from his mapping, I think that what he did in Chinese, it's what we do in Portuguese or in English. I think the mapping was, for me, was not much different. He showed some cards, the computer, and I think mapping was more or less the same than what we do.
He used some black and white pictures. I don't know how you in Campina Grande and Recife use. We usually use the Boston naming test. I think we have a Boston naming test in Portuguese, right? This is what I am personally familiar to use. What tests do you use? It's Boston, or do you adapt?
Well, there is a phonoaudiologist and a psychologist with us in the operating room, so it's up to them. I think it's the Boston test, I'm not sure. But with Professor Yudo, I think they didn't have any trouble doing the mapping.
In the mapping.
They used electronic charts, huh? Computer charts.
Computer charts, yes. And it was written in Chinese. I didn't, of course, I don't know how to read, but some people are going to put first the sentence, this is a, and then the picture. It was something written before, and this is a car, this is a computer, this is a house, and the patient has to read and name. And this is a good way of guessing if the patient has a total speech arrest. If the patient has a total speech arrest, he will not be able to read nor to name. But if the patient has just anomia, he will read but not name. He will say, this is a, and then not name the picture. So it's, although it's a small test, you can have a lot of language disturbances and do a lot of diagnosis, paraphasias, speech arrest, lentification, perseveration, anomia, dysarthria. It's a small test, very simple, but you can have a lot of disturbances. Very nice.
We are now Washington. Well, Professor Jinson is still working in the temporal lobe, I guess.
Yes, he is still in the temporal lobe and slowly climbing up.
Enquadra melhor, azul. Melhorou. Mas eu não estou escutando nada, não.
When I did the mapping, the difference that he showed in a computer, that we show sometimes in a hard papers. So, but
yeah,
the mapping
It works the same. It's the same.
also not the same. No great deal of difference at all.
Bota aqui, Adriano, é melhor tu botar, pô. É melhor tu colocar. Yeah.
So you can see Professor Jin Song working. He's going now into the temporal lobe, and he already resected the middle region and the inferior region, and now he's going up towards the Sylvian fissure. So he's going subepial. I think he's looking for the Sylvian fissure from inside the temporal lobe, just to be sure that he already resected the superior temporal gyrus.
Melhorar a luz da sala.
I think that's what he's doing.
Definir onde é que vai colocar o osso?
Yes, I think so.
Yeah. Onde vai colocar o osso aí? Marca aí.
And I didn't see the opening of the temporal horn, so I think he still
Tem som, cara, o meu.
maybe anterior into the temporal
Tem
lobe
som, meu.
and did not open the temporal horn still.
I think that anteriorly, Eduardo, I saw a glimpse of the temporal horn.
Oh, you saw? That's nice.
Yeah, but a very small hole, perhaps not entirely.
So for sure he has neuro navigation as well, because it has a lot of technology. Huashan Hospital is a big hospital. I had the pleasure to visit, and it's a huge hospital. They have all the technology we all wanted to have, and I'm sure he has neuro navigation. So this makes him more confident and fast into surgery as well. Because
let alone neuro navigation.
He's going fast. I remember his MRI, it was everything there tumor, right? So it's not the normal brain, it's just a lot of tumor there.
Yeah, I think he's working inside the tumor, huh?
Yeah, a lot of tumor, yeah. It's not bleeding, it's a typical low grade.
It's
And according to MRI, 90% of the tumor was below and lateral to the Sylvian fissure, to the middle cerebral artery.
Yeah.
Pega. Não, você precisa não. Esse tá bom. Aqui, 3 pontos. Ok?
Dr. Igor, how many people do we have online? Do you have any idea?
Well, there are two platforms. There's the Chinese platform and our platform. I can't access right now the Chinese platform, but we had more than 3,000 people.
3,000 people. Today, for us, it's Sunday night, but for them, it's Monday morning, right?
Yes, it is Monday morning here.
Monday morning.
So
yesterday
so a lot
we
of
had
people tuned in early in the morning to just, you know, have a look at it.
Yesterday
people.
Yesterday we had
So
7,000
so there is a
people.
very convenient platform to share these kind of videos here. And there's a simple link that you just click on, and everyone can quickly get access to this on their mobile phones and everywhere. So it's very convenient.
Are
And
people?
Sorry, and are people what?
No, are people at home because of the coronavirus, or most people?
No. Like, so in Shanghai right now, everything is back to normal almost everywhere. So majority of the population wears masks, and they're just doing their normal routine work. So whenever you enter a major building, you have to get your temperature checked. And there's also a code that everyone has on their phone, which shows that you have been in Shanghai for over 2 weeks. So if you have been in Shanghai for over 2 weeks, the code is green, and then you show that, and then you can enter a hospital. But if it turns red, then you have to go to, you're not allowed into public spaces. Yes, that's it, yes. So otherwise, surgeries are taking place normally now. Luckily, there is no second spike in cases here. How is it like right now in your area, Dr. Eduardo?
Well, Brazil is very big, so I'm in a different area than Dr. Wagner and Igor and Professor Hildo. So São Paulo is a very big city. We had rising spikes during the last weeks, but now it's getting stable, and people are beginning to work more, and classes for children, they might start next month. It's still under debate, but they are still at home.
So are you doing elective surgeries presently?
Well,
in the hospital?
we are. Well, we are because I mostly do with tumors, but a lot of spine surgery is not being done. It stopped. Spine surgery stopped, but tumors and hydrocephaly, and it's elective, but it's not a lot elective, right? So people were gonna do it. Yeah.
So have you had any patient come in who had a tumor and also had the virus, or?
We had, yeah. Not actually before, but we had patients who got virus during their stay at the hospital. Yeah.
Okay. So how do you proceed with them?
Here's different. Here in Recife is different. We faced the worst April and May, I guess a little bit earlier than São Paulo. But nowadays we have 1,000 new cases per day and around 10 deaths per day.
That is quite high.
Yes, and we reduce it, as Eduardo already spoke, but we couldn't stop. We performed around 2-3 elective, not elective, because this concept in neurosurgery is very hard to
define,
to establish. Yes, but around 2-3 surgeries per day during the pandemic.
Okay.
And we had an interesting case, a glioblastoma multiforme, a GBM. The patient had COVID and also the tumor.
So how did that go? What kind of protections did you use? Like personal protective?
Regular PPI and PPE, regular protective, personal protective equipment, regular ones, just N95 masks, face shields, and but in this case particularly, the patient got into in the OR. We didn't have the tests. It was in the beginning of the pandemic here. And after surgery, it was a straightforward surgery for GBM. But the patient didn't wake up. We couldn't take him out the ventilator. So immediately we took him to the CT scan and performed a thorax CT scan. And then we saw the lesions. I think that some patients with brain tumors, I don't know if Eduardo saw that, they use corticosteroids before surgery sometimes for a long period of time here. And this might be correlated with the infection, with the COVID infection.
Yeah, well, probably. Yeah, we had some patients that got the coronavirus during their stay at the hospital, but they didn't develop any pulmonary problems, any respiratory issues, and they could be discharged into the regular days. But I think it's a concern. But now our hospitals, they are beginning. I work in this big hospital, public hospital, the Hospital das Clínicas, and half of the hospital is being directed for the coronavirus. So we just have half of the hospital to work with. So spine is not doing a lot, but all the other cases are present. We're doing
And
the
are
best
you
as we can.
performing in China already endoscopic procedures?
Yes, everything is being, yes, that's right. Endoscopic procedures, and yes, everything is back to normal here.
Back to normal.
Yes, yes. Came back to normal around end of April, so it's been several months now.
I think
so like about the vaccine. Any chance to get the vaccine?
You know, like there was a research which came out recently about, I think it was on the 23rd of this month. It was published in New England Journal of Medicine, and it stated that people are losing their immunity. So people who had this infection previously, right now, they kind of lose the antibodies to the virus. So this has presented a new kind of challenge to development of the vaccine. There's speculation that the vaccine would be ready around the end of the year, but with this new development, I think it's hard to say. You just have to wait and see what happens.
Because they say here that has a Sinovac. Some state of the country is telling that
trying
the Chinese
it out.
Vaccine, vaccine from China will be soon released.
Yeah, we are hopeful that. Hoping it all generates some positive result, but this new finding that just came out recently is definitely presents some more challenge. Yes, this is worrying. So perhaps the new vaccine would require several doses, or
yes, not a single dose. Perhaps you're going to reinforce that later. So
yes.
Perhaps that's gonna be the way, 1 or 2 or 3 shots.
But it is good that several companies are trying it and are in various stages of trial. Hopefully,
different kinds of vaccines also, huh?
Yes.
You have some attenuated virus vaccines and also some other kinds of mechanism for the vaccine. So
yes, that's right.
Not about the dura opening, X style or semicircular. What do you think about? Let's discuss about that. Would you do different with the flat frontally?
So here, generally, we don't use this X style. We just use a flap is lifted along the margin. And I personally, from what I've seen, that is a little bit faster and more convenient. It makes it less challenging for junior surgeons as well. With the X style, I think you have to, it's a little bit more difficult for, I think, junior surgeons with less experience. I don't know how your experience is, yes.
I agree. I think that we must keep everything as simple and safe. The more you make things complicated, the more work you're gonna have to reconstruct, to rebuild. So the simple, if it works, keep it simple. We usually don't do.
Okay, X style. X style.
X, yes.
And people from Huaxia, do you think that from Occidental language parameter is different from Oriental ones?
So there was we actually did a study on this to map the difference in language areas between Chinese language and English. What we found that actually the language areas are different. They're slightly different, but they're generally around the same region. I cannot share the image right now, but yes, they're from our results, Chinese language had different regions in the cortex from
brain.
Yes, that's right.
People from Philippines, do you operate on Philippines, which speak
English,
like
bilingual people? No, I'm afraid most of the population here speaks Chinese. We haven't had. So what we did for that study was got consent from the patients who could speak English and try to map bilingual areas, map while they spoke in English and while they spoke in Chinese. So
and
what about their
location? Yeah.
Yes, slightly different around a tumor. These mappings were done on a tumor patient, and the locations were slightly different. For English, they had one region, for example, 1, 2, 3, and for Chinese, the regions that were mapped 4, 5, 6 were away from 1, 2, 3. So there was that difference seen in the patients we tried it on. Yes. What about in Brazil? Have you ever tried it with bilingual people? Any experience on this with anyone?
No,
Never.
mostly I speak one language here, Portuguese.
Okay.
But there was a discussion and people claiming that when people speak more than one language, the mother language will be closer to the Sylvian Fisher, and the secondary language that you learn during your life, they will be more away from the Sylvian Fisher. So I don't know how was the results of that study of the Chinese and English.
So the results were quite like I mentioned, were away from the what was mapped for Chinese was different from for English, but to have a conclusive result, it was actually difficult to find a correlation. So the reason why that happened, I think another reason why we couldn't find conclusive relationship was because people learned their language later in life. Like if you pick up a second language, it's perhaps during high school or that. So for people who learn it perhaps early in their life, if we can find several people like that, I think it will be easier to find a correlation between how the whole thing developed, how the plasticity evolved, and what you are mentioning, proximity to the Sylvian fissure and that, yes. So our patient is awake right now and is complaining of slight pain because the dura is being coagulated right now.
So it's very interesting. Most people will do just one set of awake neurosurgery. You are doing 2 sets. So the patient was awake for cortical mapping, yes, and then asleep,
slightly, so
and
right
now
now,
awake again.
Yes, he was partially sedated, and now he's awake because we are. I think the presumption is that the subcortical tracts are around this area, so to preserve those.
Yeah. It's interesting. Are you using propofol or dexamethasone?
Dexamethasone.
Okay. So no propofol.
No. Right now there is no propofol. No propofol right now.
And you did a scalp block with local anesthesia.
That's right.
And the patient is comfortable for the pain?
So right now he's not complaining of any pain, but earlier on when the dura was being coagulated, he complained of slight pain.
Okay. That's interesting. You always do 2 sets of a week?
It depends on the case generally. So for this case, this is how it was done.
That's nice.
I don't know your opinion about positioning, but when we started to perform these awake surgeries, some patients, they complained about the positioning, the arm positioning. Do you have any kind of
for this patient, a roll was placed under the left shoulder to just make him turn slightly. So I think the roll is comfortable. It's not very itchy. So generally, patients do not complain about that.
Our patients complain more of the arm position than any other thing.
Okay.
We started to look for that.
Solution to that. Okay.
Yeah, a roll.
But Dr. Igor, one of the main details is to keep the cervical spine in neutral position, right? Aligned with the chest and not with the patient bent or to the other side. Yeah.
That's a good tip. Great tip.
Yeah, and a tip also, if anything happens and the anesthesiologist needs to get endotracheal tube and you don't have the cervical spine in neutral position, he's gonna have a lot of trouble. So always try to keep it aligned. If anything happens, I mean, it can happen, right? So he's to neutral position.
To leave a corridor, an easy corridor for the anesthesiologist in case of any
emergency.
An emergency.
Yeah, also not to flex too much the chin against the chest, because if you keep the patient like this, it will be very hard to get the endotracheal tube. Yeah, so you need to be a little bit extended. It's more comfortable as well, not a lot, of course, because that's not comfortable. But you need to think about
ter tampado ali. Agora isso daqui tá aparecendo.
So, Dr. Igor, you earlier on mentioned you don't use the CUSA aspirator. So how do you generally go around resecting tumors? With just the coagulator or?
No, I like CUSA, but I do like. Professor Yudo doesn't like it as much as I do. I think it's a great tool, but properly used. Professor Yudo doesn't like.
I use it I don't use it very often, but in this case, of course, I use it. But in some tumors, I do prefer my sac, you know.
Well, and, if we are working in small corridors, it might be dangerous.
Doutor Ido, sua câmera está fora de centro. Deixa eu melhorar seu. Ok, melhorou.
I'm not prejudiced against CUSA, so I very.
Aumentar um pouquinho o som do meu.
I use it not very as much as Igor does, but.
I think it also has to do with developing the feeling of how it feels in the hand, because it is a relatively new tool in this area. I think the more recent ones.
But if I'm very medial in the insula, I like to have my SACA instead of the CUSA. But enjoy what you like mostly. Do what you like mostly.
But Shanghai is under general anesthesia now, isn't
it? The Shanghai, no, he's not. He's awake right now.
He's awake.
Can you see the face of the patient? The face? Is there a camera
on the face of the patient?
Yes.
Presently, no.
See how do you test
the face?
him?
Yes, we'll show the face shortly.
Brazil.
So I think you can
hear me.
Yes.
You have finished. The operation have finished.
We can see the patient. We can see the positioning and also the.
So this device that you see, this is what we use for our mapping, the mapping interactive stimulation system. One of this platform, the one that you are currently being shown, this is what the technician sees. He controls the task presentation, the patient situation and all that. And one of the arms presents the picture to the patient. It's placed right in front of the face. And it also has a microphone which amplifies the sound of the patient. You can also monitor.
We can clearly see the microphone.
Yeah.
That's great too.
And one of the screens is also towards the surgeon. So Professor Wu can also see one of the this same screen. So this actually makes it very convenient to map task presentation like and the task can be, you can also adjust the task based on the requirements of the surgery. You can design them, and previous to the surgery, the patient is also shown all these tasks. He's trained on them so that he doesn't have a challenge doing it later.
Oh, that's great for the audience. If you want to see this device, you must look for Huashan Hospital window and double click.
It's nice. So now it's a reading test.
No, so right now he's not actually doing anything. He's awake. I think the patient is asleep right now. He's just asleep.
We can see the microphone there. And the chart on the left. Yes.
The microphone is very good because even though the patient is awake, the patient is usually tired and uncomfortable and will not speak very loud.
Yes.
So I think, I think the microphone is very good for especially the surgeon to have a feedback what he's talking, because there's a lot of noise, the aspiration, the devices, everything makes a little bit of beeps, noise, and the microphone is very good.
Some people say that the maximum length of surgery of awakening is 2 hours. After that, the patient's gonna have some kind of fatigue. So 2 hours would be the maximum.
Yeah, but here they are doing very interesting. They are doing 2 sets of awake. They did one very short, maybe 20 minutes, 15 minutes. And now they are doing for the subcortical, right?
Yeah, the second one.
So like I mentioned earlier, it depends on the situation. For this particular case, the patient was made to sleep in between, and now he's awake again. But sometimes the patient can also be kept awake throughout the surgery. It just depends on the extent of mapping and everything.
So all stimulation from Huashan is going to be bipolar, or are you going to use monopolar?
The cortical stimulation is done with a bipolar probe, but subcortical mapping is usually done with a monopolar probe. We use the monopolar for subcortical, for motor mapping. For motor mapping, yes.
Did you use? Are you going to use any kind of task, non-verbal association test like the PPT for
so during subcortical mapping, yes, the same process is repeated. The patient can be asked to count to 1. Generally, we ask the patient to count to 1 from 1 to 50 during subcortical mapping, language mapping, or sometimes language as well, and that is it. For motor mapping, the patient is asked to squeeze their hands. You can see in the patient interface on the lower left side screen, the patient's hand can be seen. So this is where the surgeon can monitor hand responses during the monopolar stimulation.
Okay. Okay. Is the patient going to actively move their hand, or is just
yes? So he's just asked to squeeze, like open squeeze, open squeeze. Okay. Yes.
And I don't see any needles there. Are you doing electromyography or no electromyography?
No, we don't. Not doing that.
So just okay, that's good, man.
Okay. 已经讲过了。
So now he's going, Dr. Jim Song is going more posterior into the temporal lobe, probably looking for the temporal horn, right?
Yes, that's right. More at the posterior end of the temporal lobe right now.
Tá tudo parado, estranho. Diz lá que tá um chiado aqui, eu não tô vendo nada.
Tá ouvindo nada?
Não tô vendo nada, viu? Tá tudo um chiado aqui.
Ele tá, deixa eu ver se acho que caiu o sinal da rede. Aí pediu um minuto.
Só a Adrianinha aparecendo.
Tudo bem.
Amanhã deixa o Leão aí sozinho, trabalhando. Amanhã. Hã? Eu vou dar o tchau, querido. A gente tá saindo aqui. Vai ver lá o que está acontecendo. Vai ver lá com o Diego.
Okay, some people are making some questions into the chat, and someone asked, "Are you just using direct stimulation?" So I think, are you using any kind of monitoring? Because I didn't see the electromyography, so I don't know if they are using strip for motor mapping. I think they are not. How is the Huashan protocol for the monitoring? Are you using any monitoring or just mapping?
So there is a strip on the fingers placed which measures the response. There is.
Okay, there is.
Yes, there is.
Are you looking for after discharge electrical corticography?
That's well, right. That's right. Yes. So okay. After discharge, you can the results can be seen also on the monitor, on the patient interface monitor, on the lower right screen. So when there is a discharge, it can be seen there.
Okay. So if people can see there, okay. And you didn't have any after discharge because it was very low, right? It was very low.
A gente tá lá?
Okay. So they are using this strip. Someone asked, Dr. Hugo asked, so they are using this strip. And the CUSA intensity, I suppose, is very low because he's working into a delicate manner and just aspirating little by little.
So right now he's aspirating the insula. He's already at the insula, resecting around the insular lobe.
Do you know how strong is the CUSA?
The CUSA aspirator right now is at the low amplitude. It's not at very high amplitude. No. So they're like not. So it generally has these settings of low and high. So when there are a lot of blood vessels, the amplitude is set to high, which makes it more sensitive to blood vessels. So because right now you're mostly around the tumor, so the amplitude is set at low, which makes it easier to resect the tumor.
That's a great tip for the CUSA setting.
O som tá bom. Tá bom.
Our colleagues from Intuan, they are debulking the tumor, right?
Oh yeah, nice.
Yes. Very nice. Intuan.
Yes, I think in Incheon they just resected the tumor in bulk. I think it's nicely done.
Nicely done. They could find a cleavage when, yes.
And you see, as they worked a lot first in the vascularization of the tumor itself did not bleed a lot. It became friendly, just as Professor Yudo said. Now it's a more friendly tumor.
Yeah, nice job.
Vitor Rocha.
Aí eu estou no processo da frente. Aí eu fui muito amigo da tua vida, me disse, vem pra cá que eu tenho uma lente aqui.
Can you hear me? Marcos?
Hey, I can hear you. Can you hear me?
Yeah, noise from you.
Yes, can hear.
Okay. We are already finished. The bone is already in his place. I think we're gonna end our transmission here. Okay?
Very nicely done surgery. Thank you, sir.
Thank you. I hope to meet you in near future.
Congratulations, Mark.
Luciano, say hello to them.
Luciano.
Yeah.
I'm very proud of you.
Luciano.
Thank you. Thank you.
Great job.
Yeah, thank you. Bye-bye.
Bye-bye.
Pode encerrar a transmissão lá. Pode encerrar a transmissão.
Yeah, from each one, the tumor is not bleeding. It's so they cut the vascularization, and now the tumor it's still they have to work on it, but it's more friendly. You see, the tumor is pale, it's not bleeding. So they did a good job already.
Tá vendo? Manda deixar lá só a câmera desse negócio. Pronto. Deixar só essa aqui e acaba com todas as notas. Tem que ficar à vontade aqui, né? Tirar o som, tirar o som.
For the Russian team, can you hear me?
Yes, yes.
Are you using NeuroNavigator for localize the temporal horn?
So yes, we do use NeuroNavigation to localize.
Yes.
But you could see that it was the insula because there were some arteries over the cortex deep there. So probably M2 branches, right? You could see. Now there is a cotton over it, but the insula was there.
You see right now, where Professor Wu is dissecting. Dr. Eduardo, you're familiar with this region. You have papers on this.
Well, thank you. So, so just to start, he pointed first the pars triangularis, and the insula is not actually underneath the pars triangularis; it's underneath the pars opercularis. So it was now it's covered with cotton, but this is one of the landmarks. Then you can see and try to locate the insula. So now Professor Wu put a cottonoid. It's you can see at the center of the image, the insula is covered with this cottonoid, very red there with blood, and he's working at this connection of the temporal lobe and the insula. So this connection it's the temporal stem. This where he is right now. This is the temporal stem, right?
Yes, this is the temporal stem. That's right.
Yeah. So there. So he's working the temporal stem, aspirating the white matter. Several tracts go through this white matter. So starting anterior to posterior, you will have the uncinate fascicle. Then you have the IFOF, that's the inferior fronto-occipital fascicle. And then more posterior, but more posterior than this place, they will have the claustrocortical fibers, but really more posterior. So he's on the probably at the IFOF and the uncinate fascicle. And it would be a nice place to map. Are you going to map that region?
Yes.
Or not?
So that right now you're about to do the subcortical mapping. The patient will be carrying out tasks shortly.
That's nice. Yeah, that's nice. Okay, that's it. You see? Okay. Yeah.
Eduardo, do you agree with Dufault's methodology that when he says that he prefer not to use the microscope sometimes because you can lose yourself dealing with these fascicles in the white matter substance? Do you agree with him?
I think it's all a question of experience, right? I think he was trained or chose to be trained in that way. He's really strict in his manner. He likes to do everything the same way always. I think he's just his personality, and but in his hands it works. I went to see him operating, and he works without microscope, and he does a nice job for sure. But a lot of people also do a nice job with other settings. as you see here, Professor Jim Song doing his job, nice job. You see Professor Mitchell Berger using microscope, Lorenzo Bello doing microscope as well, using microscope. So I personally, I like the microscope. I come from a tradition at my university that you have to use the microscope always.
Me
now
too.
I bought some loops, magnifying loops, and I bought a 3 to 4 times amplification. I think loops are also a good choice. Yeah, a good option. But no microscope at all. I don't think that for me it would be a nice option. But I mean, I already use glasses, so maybe I'm already one step behind.
I share the same opinion. I was trained with microscope. I already tried to use only loops, but I'm not I don't get used to that.
So right now you can. So right now you'll see the navigation images.
Yes, we can see the probe. Yes.
They're just adjusting it. Okay. So this is the temporal pole which is being resected right now.
Okay. So this part, the temporal pole, it's anterior to the temporal stem. The temporal stem, it's really underneath the insula, coronal layer, coronal perspective. So this is more anterior, and he can work there safely. That's why he's not mapping that region, then he's just resecting. It's already also functionally disconnected because he already cut all the white matter. So Professor Yudo just commented that the CUSA sometimes is dangerous. But you see Professor Jim Song using this very delicate manner, using it in a low, with low power. So he's just using as an aspirator more than a real ultrasonic aspirator. He's just working easily and delicate and not rushing. Some people will use the CUSA just to do it fast, but that's not the real way to do it. It's you have to go slow and be sure where you are.
Really depends on who is using the tool, isn't it? And,
yeah.
I do remember many years ago, a neurosurgeon was marketing CUSA when CUSA was just starting in the market. So how beautiful is this apparatus? You can go over the carotid artery without harming it. So remember, Professor Sam said, and jumped up very strongly, said, you cannot promenade over the carotid artery with the CUSA. So we need to set it in a very low power when you are near the important structures. And also, sometimes if you suck too much, you lose your capacity to stop. So, of course, CUSA should be more than necessary in this case. Otherwise, it will be more difficult, more bloody, and it will take 3 times more time. But there are situations that I don't tend to use. I give it to Igor next door to my OR. But it depends. And my former good, old, and beloved professor, so you take the idiosyncrasies of your mentors. So that's why my mentor didn't like to use CUSA very much. But I think it's very good. But sometimes for a tough tumor like some meningiomas, it does not no more than silicone net.
How is your department, Professor Yudo, at Hospital da Restauração? Do you have CUSA or?
Yes, we have CUSA. We have CUSA, and we have 4 ORs operate on nice. For elective case every day, plus the emergency room, and we have 4 ORs with CUSA with microscope. Whenever you like, you navigate. Whenever you need. Sometimes we need to refrain a little bit because NeuroNavigator need to pay for someone outside the hospital. So we need to be very careful with our budget. And we are very careful. So that's why that the craniometric points that your father and Sebastian Guzman so very well described and taught us is very important for our residents to put in their minds, because most of the time our inside brain GPS is much better than the NeuroNavigator, because the NeuroNavigation in a situation like this one, otherwise you have a tool that you have in real time to uptake the new parameters. So the shift will be tremendous in this. If you do the NeuroNavigate, in some points of where you have bone landmarks, you can trust it. But sometimes the shift is very, very important. So you need to rely on a private cerebral GPS.
Yeah, I agree, Professor Udo. It's always based into anatomy. You need to know the anatomy because the brain shifts a lot. Not these deep lesions, but most lesions are not deep. They are very superficial and they will change their position. And so you need to know the anatomy.
For the young neurosurgeons who are watching this tremendous lecture, and I see if you are good vascular, I don't know whether in
so this is the
we operate on any aneurysm or any AVMs, but if you're a good vascular neurosurgeon, you should be also a very good tumor surgeon.
So the uncus is being resected here, and the third nerve can also be seen here.
Is this the tentorial free edge?
The ventricle, right?
Yeah. Well, so maybe now he's at over the tentorial edge. So this is a landmark to see that he's at the uncus.
I couldn't see the.
That's right.
Yeah, the tentorial edge and the uncus, right above.
Yeah, so he just showed us. He's just coagulating the tentorial edge, I think. Yeah. So this is the base, and this is where the tentorial edge is gonna. To your right is going to end at the anterior clinoid. So this is the temporal base. Everything that is superior and medial to this edge is the uncus. So this is where the amygdala will be. So he's just aspirating the amygdala, as he said. And you can see now that it's moving a little bit because he already aspirated the amygdala and probably just a thin layer of arachnoid covering the cisterns, the carotid cistern, the crural cistern. He's just aspirating the amygdala, temporal mesial structures, right? Yeah.
It's very important to keep the arachnoid as a barrier, as protective barrier in this area. It's very important.
You see, it's very thin. He's sucking, aspirating, and it's just as Dr. Igor said, just probably the CUSA is with very low power, just aspirating millimeter by millimeter. You see, he's working very slow, and
you can see the arachnoid, huh?
Yeah, nice.
Yes, you can see the arachnoid down there.
The arachnoid, yeah.
The P arachnoid.
Yes, yes.
Yes. Third nerve?
Yes, that's the arachnoid, and right now he's doing sub-PL resection.
Sub-PL resection, that's it.
So the uncus, posterior to the uncus, which has been resected, is the amygdala. Dr. Eduardo published a very good paper in Journal of Neurosurgery on this, on temporal stem. Remember, it was also, I think, published as the cover of the journal as well.
Thank you, Dr. Jimson. Yeah, it was my after my residency training, I went to Professor Rotten, and I stayed 1 year and a half there doing laboratory dissections. And I enforce everybody who wants to learn anatomy to get at least 1 year, dedicate yourself to the anatomy lab. And anatomy is something that you always need to know to locate yourself and to be more confident into surgery. And my subject of my research, my main research, was the central core and the fibers that go through there. And this was my major publication. And we understood all the fiber tracts inside that region, but also the fiber tracts that go to the temporal lobe, and they are the temporal stem. So it's a nice, thank you for remembering this. It's a nice article, and everybody, if they want to get the article, just email me, and I can send you the coordinates. It's a nice article. Thank you. So now he's aspirating, and I think you didn't open the temporal horn still. Did you open the temporal horn, or I didn't see CSF?
So it hasn't been opened yet.
Hasn't been opened. Okay.
Didn't open or open already?
No, not opened. Not opened yet.
Not open yet.
So this is the temporal horn at the posterior. So the patient is going to be asked to do picture naming tasks. You can see the patient is awake.
这张图片是斜，这张图片是帽子，这张图片是兔子，这张图片是老鼠，这张图片是兔子，这张图片是猪，这张图片是猫，这张图片是鸡，这张图片是老鼠，是狗，这张图片是鱼，这张图片是马，这张图片是树叶，这张图片是苹果，这张图片是花，这张图片是手指头，这张图片是耳朵，这张图片是腿，这张图片是头发，这张图片是鼻子，这张图片是脚，这张图片是眼睛，这张图片是手， 张图片是牙刷，这张图片是勺子，这张图片是床，这张图片是桌子。
So as you can see, the patient is like carrying out naming tasks right now. There is no language deficits. So Professor Wu can continue resection.
这张图片是本子，这张图片是袜子，这张图片是鞋，这张图片是裤子，这张图片是帽子，这张图片是小老鼠，这张图片是猪，这张图片是猫，这张图片是鸡，这张图片是狗，这张图片是鱼，这张图片是马，这张图片是树叶，这张图片是苹果，这张图片是花，这张图片手指，这张图片是耳朵，这张图片是脚腿，这张图片是那个头发，这张图片是鼻子，这张图片是脚，这张图片是眼睛，这张图片是手。
So you see, Professor Wu is coming from anterior to posterior because the more eloquent fibers, they're going to be more posterior. So he's going from anterior to posterior. Once the patient have language disturbance, he will reach the posterior limb.
这张图片是腿，这张图片是碗，这张图片是书本，这张图片是那鞋袜子，这张图片是鞋，这张图片是裤子。
So the temporal horn has been opened.
这张图片是帽子。
Nice.
这张图片是兔子。这张图片是猪。
As you can see, the patient
这张图片是猫。
the patient is fully awake and he's not making any errors in picture naming.
这张图片是狗。这张图片是鱼。这张图片是马。这张图片是树叶，太远了看不清楚了。这张图片是苹果。这张图片是花。 这张图片是手指头，这张图片是耳朵，这张图片是腿，这张图片是腿，那是胳膊，那头毛，图片是那个舌头，那个鼻子，图片是脚。 这个图片是眼睛，这个图片是手， 这个图片是牙刷，这个图片是条子，
Yeah,
这个图片是床，这个图片是桌子，这个图片是椅子，
a little bit there.
这个图片是碗，这个图片是书。
So the patient was asked to carry out language tasks here because she was asked to carry out language tasks because this is where the IFOF passes and the inferior longitudinal fasciculus. The language tracts are rich in this region, so this helps to preserve language function, which is also another important part of the surgery.
The question here is how much posterior he can go into the temporal lobe.
So this is where the mapping helps. It assists, because you know that the tumor is here, and the mapping helps with knowing how far you can keep going. So the CUSA aspirator is set at, it has various parameters. So presently it is set at, there is a tissue select parameter which is set at standard, and the amplitude which is set at 50%, which is used for suction in this case. This one.
So the guys from each one, you see, they are working on the cleavage plane, and they are removing a really big piece of the tumor. They already debulked it. Debulked is to remove the core of the tumor, what's inside the tumor, and then you can work on the cleavage plane between the tumor and the brain after. So they first debulked they first devascularized the tumor, then they debulked the tumor, and now they are separating the tumor from the brain. This is working on the cleavage plane. You see, now they are, one assistant is holding the tumor upwards and showing to the surgeon the cleavage plane, and the surgeon is working on this plane and putting some cottonoids and is slowly separating the tumor from the brain. Remembering that this is extrinsic tumor, right? It's not infiltrated with the brain. It's extrinsic, so it's able to really remove the brain from the tumor from the brain. You see, it's an important part of the surgery from each one. Nice job there. Is everybody looking to each one? Nice job, each one. It's going to be a very big tumor in one block, almost one block, because they already debulked, but it's almost one block. Let's see. In Brazil, we like a lot of soccer, right, Igor? So I feel like I am, you know, the guy that tells the soccer game. What's the narrando o jogo? Your microphone is not open, Igor.
You are invited to come here to see the best soccer team in the world, Sport Recife. Someday you're gonna come here to our Ilha do Retiro.
I don't know Recife. I want to go there. Let's see. It's a beautiful. People say so. We need to tell the Chinese people. Come to Brazil. Brazil has the best beaches, the best shore, the landscape, the nature is beautiful. I know now it's the coronavirus infection time, but let's see next year. Everybody,
yes, definitely
come to Brazil.
Definitely.
We're gonna overcome this pandemic for sure.
Yeah,
and
but
then
it's it's very dangerous to come to Brazil because you might fall in love with Brazil and not go back to China. Okay, so
I've never been to China, but for sure I will go. Perhaps next year or the other year. For sure, I'll go to China.
These are big countries. There's a lot to see and explore.
Yes.
It's beautiful. I've
We
been
are both
to Shanghai.
big countries. Both big countries.
I live in a big city. It's just a work city. But Igor and Dr. Where is Dr.
Dr. Ildo,
he's not here anymore. Okay, but Dr. Ildo, they live in a gorgeous city by the beach, and
Dr.
Ildo here. Yes.
You can see good neurosurgery and good city there too, and eat a lot, right, Igor?
and you can see the Sport Recife. You can see Sport Recife. Dr. Ildo is also a Sport Recife supporter, so we have the same team.
I did play.
So what is your soccer team, Eduardo? Are you
I'm not a fanatic, but I like São Paulo team. You know?
It's okay.
Okay, but everybody pay attention to each one. They are almost removing the tumor. And,
yes, it's almost at the end, yes.
So they are putting a lot of cottonoid just to control the bleeding, but it's doing like a blunt dissection, right? Just packing with cottonoid and slowly removing the tumor. It's a big tumor.
Inchuan, are you online? Do you want to add some comments? I'm not sure if they are on mute. I don't think so. But they are near the end, huh? Tough tumor. Inchuan, can you hear me? Inchuan? Huashan team, can you hear me?
Yes, I can hear you in Huashan.
Yeah.
Yes. I think Incheon team would be, perhaps they're busy in the surgery.
You see, almost removing the tumor. I think it's the final steps of each one.
Yes.
Hello.
把麦开一下，我来动，我来。好了。
Hello.
Yes, we can hear you.
Yes. So the tumor is being removed. Hello.
Yes, we can hear you.
Talk, yes.
Oh, okay.
This is
tumor is being removed most partly, and we are seeing the bleeding.
Yes, we can see it.
Yeah. So under the intraoperative, the diagnosis is meningioma.
Okay, meningioma.
Yeah. Plexus. Landmark, right? So right now, Professor Wu just resected the choroidal plexus, and above it is the
because the tumor is so huge, so we resected the tumor partly and partly.
Great job, nice.
Well done. So Huashan team, where are you now?
So he's resecting at the uncus right now.
Okay.
This is the amygdala. Sorry, this is the amygdala, and the uncus is above it. Yes. Okay. So the hippocampus was not invaded by the tumor, so it is preserved. Under the microscope, it is quite, the hippocampus can be discerned, but on these 2D images of the screen, it isn't very clear.
Did the patient have seizures? This patient of Horsham?
No, he didn't have any seizures. No
Any
seizures.
seizure? Very, because it's close to epileptogenic places, right? It's a big temporal tumor close to the hippocampus, and that's good not to have.
This is the anterior choroid fissure.
So do you do the intraoperative MRI at a certain, for routine, at a certain step, or always at the end of the surgery?
Yes, so after this resection is done, the patient will be sent for IMRI, for intraoperative scan, to check the extent of the resection.
Okay.
I guess our friends from each one have finished. So
in Horsham, you see, he's putting he just put the.
So yes, we'll show you
near
the navigation.
navigation.
Yes, just change the screen again. Wait. 你会可以跟吴老师说一下，给他们看看导航的，如果可以的话，好。So this is the transverse gyrus.
Let's see.
The transverse gyrus. So the transverse gyrus, he's resecting along it, and it points to the posterior end of the insula.
Okay, that's the also known as the Heschel gyrus, right?
Yes,
the
yes.
First,
And,
yes.
it can serve as a landmark for the posterior end of the insula, posterior point.
That's nice, yeah. So some people might ask, but can you resect the Heschel gyrus, that's the transverse gyrus, because it's the primary auditory area. So can you resect it and not cause the patient any auditory problem? So the answer would be that you have bilateral representation of her auditory knowledge inputs. So you can resect, as Professor Jim Song is doing, you can resect.
So if you want to resect this region, so the patient, if the patient is awake, you let him repeat tasks, and that can help you, decide whether you want to resect this auditory area or not. So right now the patient is actually carrying out tasks. He's speaking actively.
Free speech, or he's repetitive?
Just normal conversation.
Free speech.
Yes, free speech. Free speech.
Yeah.
Okay. Nice. Temporal base.
Yes.
So he's just resecting a little bit of the inferior temporal gyrus.
And you can posterior to it, you can see in the vein of Labi.
Nice. Yes.
Posteriorly, Labi posteriorly. Huh?
Yes.
very pale, right? Seems tumor. Very, very pale.
Yeah. Yes, this is the tumor. 看不出来 like that.
I've just been told that that's more than 15,000 people watching our event. I would say, Northeast Brazil and China. But Professor Hildo, 15,000 people.
It's unbelievable, no? It's unbelievable.
Unbelievable.
Yeah. Wow. It's amazing. Thank you very much. I mean, how important that for the teaching of the young neurosurgeon. Here in Australia, in China, everywhere in the world, people learning about this superb operation. I'd like to raise a question. How about visual field defects? Can anyone for Yuashan make any comment? I gather that there was no visual field defects pre-op. Are you forecasting visual field defect post-op?
So just to comment.
So it is likely that the patient will have visual field defects because this is task. Okay. Oh, okay. So right now they're performing a task to just like you mentioned to check the visual field, but it's likely that the patient will have.
See, perhaps an upper temporal.
Yes.
Upper.
Yes, on the upper left corner, yeah. Since the resection is around the temporal lobe,
it is a big tumor. People are watching, and of course, the idea here is to have oncological impact on the patient survival, minimizing the deficits. And sometimes it is okay to have a minor deficit, then you can still have a good quality of life. If you, on the other hand, have a very good oncological impact, right? So even though the patient has a visual defect,
so right now you can see that the patient is carrying out a visual task. She's being shown a clock, and then so far she's being able to read out the timing well. Yeah, 8:15. She can read it. So her visual field is actually preserved.
I never saw this test. We usually use two images, one on each side of the screen. So you use a clock. That's interesting.
So this can also measure her spatial
awareness.
Yes.
Okay. That's nice. That's nice. And the patient has to focus in the middle of the screen, right?
Yes, that's right. So she's reading all the times well, making no errors.
5点40分。
So how do you presume the patient can still see despite the large size of the tumor? Dr. Eduardo, what do you think is the explanation for this?
10分。
Well, brain plasticity is one explanation, but more than plasticity is maybe the tumor is just pushing the fibers away from the tumor, not actually it's not actually drawing the fibers, just pushing them to another place. What do you think?
That is the explanation. Yes, that is.
5点40分。7小时35分。
But a lot of visual defects symptoms, they are still compatible with a good quality of life. If you have a quadrantopsia, it's not a huge problem. It's the patient can have a normal life.
1点35分。
He's not making any mistakes.
That's good.
4点35分。
Yes, 4:35. She's right.
11点35分。
They have a practical.
15点。 2点30分。 9点35分。 2点55。
Oh, damn. She's good.
7点15分。 7点30分。 10点20分。 2点30分。
It's okay. So you can ask the patient to rest.
Depending on the literacy of the patient, do you have several levels of tasks for?
So the tasks, yes. So prior to the operation, the patients are assessed for their level of education and all that. Most of the tasks are quite straightforward and simple. So we haven't actually seen a patient complaining of difficulty in reading the tasks or in this area.
Yeah. Thank you.
But of course, if a patient cannot cooperate with this, then I think other alternate ways can be used. I haven't seen it happening yet, but. So the insular is being. The templar lobectomy has been completed. Now the inferior portion of the insular lobe.
Is this the MCA or the third nerve?
So this can be a challenging part to resect because of the vascularity, the MCA branches. So you have to take your time and create the corridors in between the vessels. So right now the amplitude of the CUSA is constantly being adjusted. So right now it is at low tissue select parameter.
Very nice. So you are aspirating the insula inferior to the M2 branches, not between the M2 branches. Is that it?
I think they're working underneath, huh?
Yeah, underneath.
Thank you. And
Like,
small holes between the
at that part now he's between them two branches at this part. But
before he was working underneath the main track.
So he's using two plans to do. Yeah.
Professor Eager is here. Hi， 没听着？我们那个麦没开，没有，我们那个没开，静音的，你看静音的。Hello. Thank you.
We can hear you.
Yes, we can hear you.
Yeah. Yeah, Micros, are you here?
Marcos left. He finished the surgery and he's trying to get in again.
Okay. Okay, Professor Eager, you is here,
Yes.
and another professor. Okay, so much. It's very sorry, it's too late.
No, very nicely done.
Dr. Iderado and
Yes, I'm here.
Dr. Yeah. Thank you, everybody. I finished my work. So because it's a huge meningioma have some relation with venous, but bleeding. But I'm afraid to damage the venous. So and also have some trouble of drainage. Drainage cannot move, cannot work. So it's I'm so sorry, but I finished it. Can you give me some suggestion, or maybe you can told me some things?
I think your plan for surgery was perfect. I think you devascularized the tumor, then debulked the tumor, and then worked on the cleavage plane. I think it was a good way to do this case. I agree with your plan, and I think you did a great job. It was a great job.
Yeah, I do agree with Eduardo. Great job. Devascularized, debulked, and dissected. The 3Ds for meningioma surgery. So great job.
Yeah. So because this case is we just change. Before 1 week, we prepare a glioma. We also want to prepare a case of low-grade tumor and to fit to the awake surgeries. But it's the patient's family and his relatives very hesitate. So we decide to change the case. So, but I think to remove meningioma, it's hard work, but not having the good logistic opinion and idea, such as Dr. Jin Su's was finished. It's really temporal lobe have many things about the functions. But I'm also very sorry. This is my first time live broadcasting. I'm so shy and I'm so feel nervous today.
Very, very nicely done. Very good.
Yeah,
very beautiful.
With my friend, with my brother friend, helping and support. I feel I think in the future we can do much more such kind of activity. Yeah, it's very, very lucky and very happy to meet you and my friends. So thank you very much. Thank you very much.
We thank you. We thank you, Professor, and congratulations to all your team for the nice job. Perfect.
Yeah. Yes, thank you. I finished my work. Yeah, I finished my work. Okay.
Thank you very much.
Let's see the operation of Jin Song. I finished. Thank you very much. Ciao.
Thank you.
Ciao, grazie mille.
I do appreciate it.
Congratulations.
Thank you. Thank you.
Washington team, it's up to you now. Okay, we're back with you.
Yes, so still at the insula, on the underside, inferior insula.
So now he's working underneath the M2 branches. You see, he's pushing the M2 branches with the aspirator superiorly. Okay, now between the M2 branches. So he's using these two approaches. Professor Ildo said that you based your education with Professor Yashirgil. He's more familiar with working between the M2 branches, right, Professor Ildo?
I think he's on.
I feel safe when I see the two branches from the very beginning, you know.
Yeah.
Hi, everybody.
Hello, Marcos. Welcome back.
Thank you for support. Everything was done, and I'm at home. Professor Ma has already gone, finished his case, yes?
Yeah.
It was a meningioma.
Yes. Confirmed with the pathology.
Which site?
I think it was parietal one. Huh?
Mm.
Yes.
Yeah.
Ô, Marcos, tá um lugar bonito aí.
No, it's just a lake.
Just a lake. Is it your city or?
Yes, in the center of the city there is a lake. Dr. Udo likes to run around Sud Velho. And do you feel differences among ultrasound aspirators? CUSA is the best, or are there different ways of using? Can you have an opinion about it? Sonoka.
Well, I go to some congresses, and in my university we have the Sonoka, but they always claim that the CUSA has one more property, that's the tissue select function, and at the tissue select function you can preserve more the structures, the vessels. We usually use the Sonoka, not the CUSA, but maybe this is a better. It's better.
Mm-hmm.
And I think that
so now,
the difficult.
Okay.
No, the difficulty of that part of the surgery that Professor Jin Song is doing right now is trying to understand how deep can you go inside the insula. So he said that he showed this case before, and this tumor, it enlarges the space between the cortex and the lentiform nucleus. It does not go inside the lentiform nucleus. It enlarges these more superficial layers of the central core of the insula. So, of course, in the normal anatomy, these layers are very thin, maybe 1 centimeter, maybe this, but this patient has a big tumor, so this space it's enlarged. So how deep can he go? And this is the question of this step of the surgery he's doing right now. And he has neurophysiology, he has intraoperative, he has neuronavigation. We were talking about brain shift, but usually the insula does not shift a lot. I think they could comment on this because it's, I think they have more experience with neuronavigation and insula, but it might not shift too much. You can rely on preoperative based neuronavigation to answer this question. How deep can you go into the insula?
So like you said, it doesn't shift a lot, but later on when the intraoperative MRI is done, it is used to recalibrate the imaging and the neuronavigation to readjust the positioning. That is another advantage of getting an IMRI.
Right. That's a great advantage to have a intraop MRI is to recalibrate the
navigation. Yes.
Yeah, that's absolutely true. Yes, fantastic.
How long does it increase the surgical time, a procedure of intraop MRI? About 1 hour, just?
No. It takes an intraoperative MRI takes around 20 minutes, 20 to 25 minutes. So the whole process takes about less than an hour. 20 minutes. Around 30 to 40 minutes.
Yeah.
So you're going to recalibrate the neuronavigation, but can you estimate how much does it shift under your experience? It's really.
So we are hoping that the IMRI will show a gross total, like a maximal resection at the first attempt. That is the goal.
Okay.
And if there's a chance there is a residual tumor, it will be taken out. But as to whether it shifts much, it doesn't usually shift much.
Okay.
Yes.
Okay. So would you think you would be confident and safe without using intraoperative MRI?
Safe as in how?
No, I mean you would be confident with the. I mean, it doesn't shift. You can base your.
Yes. No, there's usually no problem with it.
Okay.
No problem in doing that. Yes, and we actually found that it's quite helpful. It has always resulted into better surgical outcome.
Okay.
With the data that you have with the intraop MRI and we recalibrate the neuronavigator, can you measure afterwards and comparing the two studies how much and how big was the shift?
Regarding this, I'm not sure if there's been a study by this.
Even, I mean, for the others, I think there would be a lot, but for the
we found out that it doesn't actually shift that much. It's like very little, but it is a good point to investigate this as well. Find parameters to check how much to.
It'd be a good research project.
Yes, yes.
Yeah, because a lot of people will not have intraoperative MRI.
Yes, it is a very expensive equipment to have. So
yeah,
yes.
So it's absolutely
Tesla.
possible for having in the most of the public hospitals, only quite a few in São Paulo and the south of Brazil. But I think it's not patriotic to ask for intraop MRI when I have so many things missing and lacking in our national health service hospitals, But then with such a big opening, you could use ultrasound. So it would be very easy for a probe to be inserted there. And
so it is MCA branches, and he's working between them?
Yes, working between the MCA branches. So right now,
what about the perforators?
If I'm depicting rightly, there is a very early bifurcation of the frontal M2, isn't it? Am I right?
O que vocês acham das perfurantes aí? Elas estão em risco, né? As perfurantes da cerebral média.
Yeah, but he need to pay attention on the medial side, on the M2 and M3, the medial side. But now I think
the perforating arteries, the lenticular striate arteries, and so while he's doing this, an important thing that has to be mentioned is that the Kus aspirator is being constantly adjusted. It's like it's being constantly, literally after every suction, it is being adjusted. That is another important point to mention at this.
It's like an intelligent aspirator.
Yeah, but it has to be. The surgeon is also constantly, adjusting according to his feel of what he's experiencing with it. Yes.
A hard-working process to skeletonize all these branches, huh?
Yes, it is time-consuming.
And sparing the little perforator, huh?
Yes. How many Tesla is your intraoperative MRI?
Three Tesla. Three
Tesla.
3 Teslas.
Great.
Open field.
Open field.
Yes.
Yeah. Do you think that it gives more information than the traditional 1.5 test?
It gives you a clearer resolution, I think, slightly better, yes.
Is it faster or no?
About the same time,
You have many in China operating centers like this?
Just in Shanghai. Intraoperative MRI. I think in China presently,
your intraop MRI is a Chinese-made one?
In China, there are 16
yes, but
MRI. In our hospital, we have three operation rooms with.
But I mean, this machine was made in China or elsewhere?
Sorry, the sixth.
No, your
made in
MRI.
China.
Are they made in China, or they are Chinese made? Or this MRI that you're using, this OR, is it Chinese made?
No. All the MRIs are imported.
I see.
So you have 16 for the whole country and 3 of them in your department.
No. Yes.
Yes. You have 3 fully equipped ORs with an intraoperative MRI.
I have been at the Tianjin Hospital. Your department is bigger than the Tianjin Hospital, Beijing.
It's the major one in China.
So our hospital has several branches. That is why we have more than one. So gotcha. This center where we are operating from right now has one, and another branch has another one.
It's almost 140 neurosurgeons, yeah?
Yes.
140.
And how many procedures per year?
Over 10,000 procedures a year.
Over 10,000. Do you have trauma or
yes.
only elective?
We do also have trauma center. There's a trauma center. So usually
among the 15, there is trauma.
I did mention yesterday that we do 3,000. So compared you, we are miniature.
So we usually have over 3,000 cases of tumors a year. The others are other categories.
3,000 altogether.
So over
3,000 just tumors. Yes, tumors.
Over 3,000. That's right.
Let me ask you, Professor Zhao is still the chief of the Tianjin Hospital?
Yes.
He was very kind with me when I was last time in Beijing.
Yes, he is still around.
He gave me.
Dr. Are you accustomed to use these multiple window techniques in insular tumors?
So for insular tumors, this is usually the approach to them. You have to create the windows. In this particular case, I noticed that there are more windows than usual. Other times you can have like 2 or 3 windows. It depends on the vasculature. So right now the patient is actually
We also use this technique, the multiple windows, but not so many windows, no? 2 windows, 3 windows.
So right now the patient is actually carrying tasks.
Naming task? What task is he doing?
A motor task.
Motor task, okay.
Yeah.
Do you do bimodal tasks? I mean, motor and language at the same time, or just one at a time?
So presently, he's just doing motor task. He's just being asked to squeeze and open his hands.
Okay.
We can see in the other window, Huashan Hospital. Double click and it's possible to see.
There is a rat right now.
I gather that in China you have very, very many dialects. How do you cope with these people speaking in this dialect?
So this is so the limen of the insula is being resected right now. And then the first branch of the lateral lenticulate striate artery.
Are you already seeing it? I can't see from here.
It's quite deep, so I think it would be hard to see clearly on the screen.
Coming back to language mapping, I gather that you have very many dialects in China. How do you cope with?
So So the dialect that is used here is the common Mandarin dialect, which is preferentially used. So almost everyone can speak that.
Almost everyone can speak Mandarin. Yeah.
So this, what you see here is the lenticulostriate artery.
Oh yes, fine, absolutely fantastic.
Yes,
fantastic.
Those are the lenticulostriate arteries.
Oh yes, great, fantastic. That was
beautiful.
Just, yeah.
So you see the patient is actually squeezing his hands right now.
And so I mean the tip, the best place to find the lenticulostriate, the first branch, the most lateral branch of the lenticulostriate is midway in the MCA. You know? You are midway in the MCA, halfway between the carotid bifurcation and the MCA bifurcation. Oh yeah, oh yeah. I think that together demonstrating the hippocampus, I mean for the young neurosurgeon, and demonstrating this artery is the two most important steps in this surgery.
So right now, the anterior limiting sulcus of the insula.
Nice.
The anterior. So here he is at the anterior, close to the anterior sylvian point.
Nice. So the lenticulostriate arteries, they usually go towards the lentiform and not to the external capsule, claustrum and external capsule. That's where the tumor is. So one of the tips actually that Professor Yashagil uses is to see the sylvian vallecula. The sylvian vallecula is the measurement between the lateral part of the insula and the most lateral lenticulostriate artery. So Professor Jinson is working everything lateral to the lenticulostriate arteries, right? He's very safe on the vascular point of view, right? It's not, they are not going to this region that he's aspirating. It's going more deep. Yeah. That's why it's safe on the vascular point of view. Of course, functionally, he has to work with the patient awake and stimulate. But thinking just about vessels, he is working into a safe zone.
What kind of anesthetic do you use for the method pins for the patient for support these long hours surgery?
Precisely what she's using right now.
We usually use hopivacaine or bupivacaine in the pins because they give a longer time of anesthesia. Lidocaine, for example, is very good, but it's very fast, right? So it's not a good option. But it's my point of view. Igor, what would you use?
Same thing as you.
Same thing, yeah.
Same thing.
Do you prefer to do like a ring scalp block, or do you
Like
look for the nerves like a crown?
No,
Yeah.
like a crown. Yeah.
Like a crown.
How do you
yeah. Well,
also like a crown?
No, I look for the nerves. They have some places that you can do the anesthesia, but I think the crown is good. It's not a problem. Of course, you're gonna use more volume, but you're gonna be safe. You're gonna be sure that everything's
That's
gonna
all
be
the
under
points
anesthesia.
having blocked. Yes.
Everything, and that's it. It's good. Questions of preference, right?
All right.
And the anesthesiologists, they are always claiming that we use too much anesthetics, too much volume. But I never saw a problem using,
So our patient is currently on dexamethasone and remifentanil, only on these two drugs. He's awake.
Do you give anything for nausea or no?
Just a second. So this is the superior limiting sulcus.
Yeah.
Nice.
So you're asking, these are the only two drugs that are being used. Currently, no other drug is being used as an anesthetic.
What about antiepileptic against seizures?
No. Presently, she's only on these
And do you need to inject the anesthetics or local anesthetic or not? Just once. To reinforce the dose. Local.
So Professor Wu is not going to go through the frontal lobe. He thinks these windows are sufficient to extract all of it. How to see the?
I think it's hard it's hard to know when to stop deep there.
So we use neuronavigation at this point. They will just change the window.
In the deepest portion of the window, do you use NeuroNavigator?
Yes. So the neuronavigation it will be used to check the extent.
Yes. Well, sometimes I guess that the consistency of the tumor also helps to know when to stop, huh?
That's what Professor Udo was saying, that you can hear the tumor or you can see the tumor. Sometimes the tumor is easy to see. You see, it's very pale, and so it's frankly tumor.
When Professor
to hear the tumor is a little bit difficult, but to see it, it's easier.
Well, let me say, when Professor Yashigil told me that he could recognize just by the sound of the taka, I said, Professor, I'll stop here. I cannot say because you are too much. Okay, only you can do that. So I'll stop here.
It reminds me when Professor Bertalanffy says about the optic glioma that he can find a cleavage plane. So
yeah,
I'm not at that level yet, but maybe someday.
But I've seen he find a cleavage plane. I have seen him operate on.
I do believe, but I cannot. I still cannot do this. It's very difficult, I guess.
Talanf is a great guy, very respected, and I've seen him. He showed me how to differentiate the cleavage plane in a optic apparatus glioma.
Well, I have a question. Do you use papaverine in this surgery? Embedded cottonoids with papaverine in order to mitigate the vasospasm or not?
Yes, it is. We do use it. Papaverine is used. Papaverine strips.
Yes. And I can see you don't use frequently coagulation. You avoid maximum to use any kind of coagulation.
And wherever it is possible, yes. So papaverine strips are being used here.
Yes, I can see the papaverine cottonoids.
So, so now you can have a look at navigation. Navigation is being done right now.
Dr. Edo, where did you saw Professor Yazagio? In Zurich?
Yes, I did visit. When I was doing my training, my professor there in Oxford arranged me to visit him, and I did, and I did repeat a couple of times more.
In Zurich University Hospital.
Yeah.
And he just operated with his wife. Scrub nurse, yeah? Is his wife.
Yes. No assistant, just her.
Hello.
Hello.
Hello, Professor. How are you?
你好，你好。
Yeah, 你好. Why are you being migrants? Holiday?
No,
I'm still here.
这个换到哪里？
I went home and then I'm here again.
Okay. You stay at home?
Yes, I'm home now.
The wall looks like real.
No, it's a lake in my city here.
Oh, okay.
It's a museum, yes.
Okay, you are smart. Yeah. Professor
Good surgery. I saw the final result. It's 100%.
I feel nervous, not very good, but I try my best. I'm Italiano, you know?
Mm-hmm.
Like hot? Honest, just to show my work. It's enough. First time for live broadcasting, so very happy.
I hope there will be much more now again.
Yeah.
The first case is difficult, but day by day you get accustomed, like Professor Jin-song.
Yeah. Brazil, yeah, you have shown low-grade glioma is location in BRCA errors. It's a pediatric child patient. It's I think have difficult to preserve functions. But for pediatric case, it's have good recovery in the future for neurological subjects because it can grow and to reconstruction is more better. But operation to too long time or too much more bleedings, much more a big problem. But I see, before operation, I see it's very good operation. Yeah. Yesterday, our colleagues in Yinchuan to see Brazil technician of technique of surgical and opinion idea about neurological is very good, advanced.
Thank you.
Neurosurgeon. Yeah. And also Dr. Eager showed the infrared substandard approach to remove pineal region tumors. So very amazing, very wonderful. Yeah.
Thank you, Professor.
Yes.
For your kindness.
Because Brazil, we don't have one pattern in all neurosurgical department. It varies from region to region. Our region, Northeast region, it varies a lot. But day by day, we're getting stronger to spread the techniques from every city, which has a neurosurgical center.
Yeah. 劲松是做的手术是，我没看那个病例，他是个啥病例？我说他那个病例是倒叶子嘛啊，唤醒吗？还是唤醒啊？In China, because I cannot know much more, but in my regions, Jing Song is a topist in glioma, in function brain mapping, cortic brain mapping, and he also have do many clinical research. He keep long time to focus on it, including function MRI, including intra-operation monitoring physiology. He do much more, and also he conclude a procedure of awaken assessor. Keep everything detail is very correctly. I think the case is difficult because he finished every detail of awake assessor, including ECS. He already removed.
So now you're carrying out subcortical mapping.
Yeah, cortical.
Subcortical. The monopolar probe is being used.
Yeah, monopolar. Yeah.
You are already very deep, huh?
Subcortic stimulation. Subcortic stimulation.
Why do you prefer monopolar for the subcortical?
Professor Hindle is already. Always stay here. Thank you.
Oh, it's a pleasure. Your surgery has been a masterpiece, Professor. I'm very glad to stay here. I don't feel sleepy at all. So, until you see your MRI.
Professor, I show my respected for you. Very happy to see you. You are great.
Oh, yes.
Yeah.
I hope to see in China, either here in my state, where I'm see.
Yeah. My boss.
Let's establish links between our universities.
Yeah. Yeah. Okay. Because yesterday, my boss, president of university, also come. He is a functional surgeon, and 20 years for administration. Yeah.
So now you're going to get ready and do the intraoperative MRI. All the landmarks that we wanted to approach have been approached, were revealed, like the anterior insular point, the superior insular sulcus, and the posterior point as well. So the next step would be to close up and then carry out IMRI.
Professor, if I might ask, while you are doing the MRI, could you show us the last pictures of your neuronavigation?
Oh, okay, yes.
哎，那个谁，少才，你今天那个
So you can follow the neuro navigation now. Just going to do a thorough neuro navigation.
Yeah. Anterior.
Great.
Yes, the anterior point.
Yeah.
The inferior point.
Inferior point.
No,
almost done. All the tumor is
wow,
out.
fantastic. Wow, absolutely marvelous.
Yes, almost.
Immediately.
And
absolutely. That's the beauty of our specialty. Excellent. Amazing. Yeah.
It's almost 4 hour surgery or 3 hours?
Yes, so 4 hours, over 4 hours. About 4 hours, yes.
Oh, great time.
So
at least I had a cup of tea.
So subcortical mapping showed that the patient had no motor deficits and the language functions were also normal.
Very nice.
I know the answer, but could you explain to the young neurosurgeons why you are using subcortically the unipolar stimulation?
The monopolar probe evokes better action potentials for motor functioning.
Yeah.
But what about language mapping at the subcortical level? Then you would use bipolar?
Just confirming the language functions. And another advantage of, like you see that most of the language function is okay. So another advantage of using the monopolar probe is that it can help you measure the distance perpendicular to the probe's end, because at the deep end, you're actually checking for how deep the fibers are. And for the bipolar probe, it helps you to measure the distance between the probes.
Yeah.
That is another reason why it's used.
Melody, can you hear the exact name that she's speaking in Chinese? É bem claro o que eles estão falando?
Oi?
É bem claro. A descrição é bem legal, assim, para entender.
兔子、大兔子养的才变。压挤涂面伸动脖子的衣服，要把它变成小老鼠的咬嘴巴。
Mas por que ela não fala só cavalo?
Yeah, the patient is a little tired. What she's saying isn't very clear, but she's speaking.
It's not wrong.
Percebi que ela tá cada vez mais cansada.
She's tired.
É verdade.
Yeah, she has been awake for the last quite some time, so it's expected.
When you take the patient to the MRI intraop, do you remove the Mayfield clamp and put it back again or not?
Most of the equipment in the OR is MRI compatible, so the clamp and is not removed.
Oh yeah, thank you.
Igor, qual a dificuldade que você teve em Recife em fazer o paciente acordado assim? Seleção do paciente?
Assim, o principal é na seleção a capacidade de entendimento e colaboração do paciente, né? Alguns pacientes a gente perde, não consegue fazer acordado, pacientes muito ansiosos, pacientes com nível de instrução baixo, então isso dificulta um pouco. Outra coisa também, anestesia, né? A gente só consegue começar quando tem realmente bons anestesistas treinados e a participação pré-operatória do pessoal da fonoaudiologia e da psicologia também. Tem que fazer um teste pré-operatório com esses pacientes.
É muito imprevisível na hora, né?
Você pode acabar tendo que converter e... Assim, eu nunca tive que converter, né? Eu e Eduardo temos feito muitos aí, nunca teve que converter um paciente, mas teve uma vez que deu um trabalho e um adolescente também de 12 anos, 14 anos, que demorou a acordar. Entendeu? E tem que ter paciência nessas horas. Tem que esperar que ele vai acordar, mas tem que ter paciência.
Ô Marcos, a nossa fono é muito boa. Ela foi minha aluna do doutorado, eu fui supervisor dela, ela fez uma excelente tese de doutorado que publicou na World Neurosurgery, um dos papers mais citados sobre distúrbios de linguagem e cognição após hemorragia subaracnoide. Se você tiver uma moça aí que quiser vir estagiar com ela, É uma coisa
É
fundamental.
porque
Tem que
fono
ter
é difícil na nossa região, é difícil.
tem que ter uma boa fono que queira ter uma visão acadêmica e que esteja ligado numa faculdade. Eu vou conversar até com o Dalton para ver se ele tem alguém. É importante.
É para ir testando, né?
É verdade.
Você tem que ter uma moça comprometida com a pesquisa, uma moça formidável. A tese dela foi fantástica, os papers dela são os mais citados hoje.
Eu comparo isso aí com as cirurgias fetais. Se você não tiver uma equipe, o processo não vai para frente, não tem como. A cirurgia é a ponta do iceberg, né?
É só um ponto mesmo. Né? E outra coisa também é você colocar a cânula intranasal. Vai lá não fica só no... Tipo uma sonda nasal, você vai até a laringe. E fica com oxigenação boa. The oxygenation is good.
Realmente uma craniotomia pequena, né?
So now the patient is going to be sent for IMRI. His dura will be closed first.
Sorry, I know it's very. Oh, 麦克风打开。
打开了吗？吴老师的 microphone。不能听见，不能听见。
啊，不用了。I know it's very late in Brazil, so I'm not a fast operator, so it takes much time. Of course, insular sometimes will take much more time than pure temporal lobe glioma. So now I want to perform intraoperative MRI evaluation. So I suppose 90% at least for this case. In case 90% total resection, I will stop. And now the patient is free from language disorder, just a little bit hesitate for picture naming. As I mentioned before operation, he got suffered from some neurological disorder in picture naming. So no motor deficit at all, and he can recognize the clock clearly. So I think I think the space negligence he is free from the space negligence. So this is today's surgery. To my opinion, of course, it's also corresponding to Dr. Riba's textbook. So for insular glioma surgery, we should reach the anatomical landmark, the inferior limiting sulcus, superior limiting sulcus, anterior limiting sulcus, and the meeting point of anterior and the inferior is the Lyman insula. There you can see the first branch of lenticulostriate artery penetrate into the basal ganglia. And the anterior insular point is the meeting point of anterior limiting sulcus and the superior limiting sulcus. And there is the isthmus and close to the frontal horn. And the superior margin is the superior limiting sulcus, and the posterior margin is the posterior insular point. This is the meeting point of the superior and the inferior limiting sulcus. And there you can see the terminal of the M3. So I suppose I reach almost all the margin. Of course, the deep margin is the putamen. There you can see the first branch of lateral lenticulostriate artery. So that's what I want to mention. Now we will perform MRI scan. Behind me is the shell door between the diagnostic room and the operating room. And after draping the patient, I will open the door and move out the MRI scanner. Thank you. Thank you very much.
Very good job. Very good job.
Thank you. Thank you, Professor. Thank you, Professor Hudo. Thank you.
Bravo, bravo.
Thank you. Bravo. 谢谢，谢谢。道雅语怎么说 ？Obrigado, obrigado.
Arigato.
De nada, de nada.
Obrigado.
Marcos, acho que a gente pode encerrar por aqui, né?
Você quer ficar mais um pouco não, né? Tá bom, tudo bem.
Cada hora.
Ok. Claro, claro. Mas
Well,
foi um sucesso,
professor...
acho que
Ô,
tem
Marcos,
muitas
você
pessoas
consegue...
assistindo na audiência.
Ô, Marcos, você pega as imagens do MRI amanhã e manda pra gente.
Certo, professor. Vai ficar tudo no YouTube. Eu vou mandar para vocês. O link está gravado pela Neurosurgical TV. Para sempre.
Professor
Vou mandar o link
Jinson.
para o senhor, doutor Wilson.
Professor Jinson, can you hear me?
Yes, he's here. He's here. Yes.
Okay, we due to the Brazilian time, it's almost
Excuse me?
1. Can you hear me?
Yeah.
Well, we are advanced in our time here. In our
Yes,
Brazilian
understand.
time, it's 1 p.m. So,
Yes.
First of all, we would like to thank you very much for the outstanding surgery.
Thank you.
For your kindness and patience from you and for your team in sharing your knowledge. Thank you very much. Hope to see you soon.
It's my honor.
And as Professor Yudo told, hope to build so many bridges between Brazil and China. I would like to thank also Marcos, Eduardo, Professor Hildo for being here with us till now. It's an honor to have you here, Professor. Always will be. Professor Eduardo Ribas, I have no words to thank you. Thank you very much. Your presence here showed us how important it is to have friends. So I hope to see you here in the Northeast very soon. Hope to work with you together in the future. Thank you very much. It was an honor to have you here. And if anyone has some final remarks, please be my guest to speak.
Thank you, professors.
Thank you all. Thank you for your kindness. Obrigado. See you later. And I will share the PPT after surgery. Thank you. Thank you, Professor. Thank you, moderator. Thank you, Eduardo. Say hello to your father.
Say, I'm gonna say to him, thank you for the invitation.
Thank you, Dr. Lee.
Great
Thank
surgery,
you, Dr. Lee.
Send a hug
very much.
Thank you, obrigado. Thank you.
Nice
谢
to
谢
see
李大
everybody.
夫，也谢谢马主任。
辛苦了，就说。
这个机会，谢谢这次的合作。
Eduardo, you wanna say something, Eduardo? You wanna say
No,
something?
I'm great night. It was a special night. Thank you for an invitation and congratulations for the Northeast of Brazil and China and everybody that got in this event. Thank you for the invitation. Congratulations.
Good night.
Good night. Have a good night.
Good night. Professor Ma.
Yeah, thank you. Thank you.
Have a nice week. Stay safe.
Melody, say hello for them.
Good night.
Yes,
Good night. Yes, thank you very much. Okay.
Thank you very much.
Bye. Bye.
Melody will give a Brazilian message for you, Professor, from our heart.
Okay. Okay.
Oh,
Melody is going.
Okay, yes. 非常感谢上海复旦大学附属华山医院，还有宁夏医科大学总医院与巴西北部神经学会的合作。同样也感谢所有在跟着直播的观众。如同中国人所说的“活到老，学到老”，所以非常期待下一次的见面。谢谢。
Thank you.
你好吗？
Yeah, very good. Very good. Ciao. Ciao, grazie.
Ciao.
Bye. Bye.
Não, não, deixa eu lá, 1.7.